Assalamu alaikum wa rahmatullahi wa barakatuh. Once again, we meet for the third time for our revision of the endocrine course. I hope everything we have discussed till now is clear. Yani, I hope there are no problems in case you are studying. Yani. Any problems so far? Any problems?
لا تمام يا دكتور.
Okay, طيب. A quick reminder of the ground rules by which we abide through the meeting. Please, at all times, keep your microphones mute to lessen the background noises and the echoes. And whoever wants to speak, please raise your hand so that you are allowed to unmute and talk. And feel free to ask whenever there is something you don't understand or you want me to repeat, or if I'm going too fast, okay? Feel free to eat or drink during the meeting. We are all sitting comfortably at home. Unlike in the ward, you're not allowed to eat or drink in the ward, okay? Last time I told you we're going to revise parathyroid diseases, and hopefully if time allows and if you like, because I don't think we will be able to hold a fourth revision session, because if we finish today with the parathyroid disorders only, you will be left with the adrenals, the diseases of the adrenal glands. So it depends on you, actually. If you want me to revise them today as well, tell me. If you want another revision session, a fourth one, also tell me, because as I said, and I keep saying, I'm here for you. Okay? Now let me, any suggestions or comments? Feel free to tell me.
يا ريت يا دكتور لو كلهم ناخدهم النهارده المرة دي.
طيب يعني هتستحملوا معايا؟
يعني.
انا ما عنديش مشكله. لو انتوا هتستحملوا I don't mind. يعني you tell me. خلاص according to your pace. ماشي؟ Okay, now let me start sharing my screen. Dr. Mona, autopilot. Again, you didn't tell me your name because I'm taking attendance and I muted your microphone, okay? So if you kindly can state your full name in the chat, I would be very thankful. Now let me share my slides with you. Please let me know once you see my slides, okay? Can you see them now?
Yes, Doctor.
Yes.
Are they small or in slideshow?
In slideshow.
Great. Are they moving or fixed?
Moving.
Moving. Great. So the intended learning outcomes of today, I'm going to, by the end of today's session, you will be able to list the symptoms and signs of hyperparathyroidism. You are going to understand the various imaging modalities in hyperparathyroidism, including plain X-rays, ultrasound, CT, MRI, and technetium sestamibi scan. And you're also going to be able to detect the clinical presentations of hypoparathyroidism, and these include the acute and the chronic forms of hypoparathyroidism. And you're going to be able to list the signs of hypoparathyroidism. You're going to be able to enumerate the investigations of hypoparathyroidism and to understand some conditions mimicking شبه يعني hypoparathyroidism اللي هما pseudo hypoparathyroidism and pseudo hypoparathyroidism. Okay? Now let me start with hyperparathyroidism. On this diagram, you can see the clinical manifestations of primary hyperparathyroidism. A patient usually presents with anorexia, nausea, vomiting, excessive thirst, dyspepsia, constipation, abdominal pain. The patient may even develop chronic pancreatitis and calculi. The patient can also have hypertension, renal calculi, or nephrocalcinosis, polyuria, proximal myopathy, again, you see, general aches and pains, bony aches, that is, and pseudo gout and chondrocalcinosis, bone cysts and brown tumors, especially osteoclastomas of the jaw. I'm going to show you a picture of that. And corneal calcifications, don't forget to look at the cornea. In addition, if the patient has multiple endocrine neoplasia type 1, there may be evidence of pituitary tumor as well. Or if the patient has multiple endocrine neoplasia type 2A, there may be evidence of medullary carcinoma of the thyroid in addition. Okay? Now, let me show you. This is band keratopathy. This is an advanced case. You see, this is the cornea. Can you see my cursor? Let me transform it into a laser pointer better. This is the cornea, okay? And here you see the cornea is as if it is an hourglass. So here's 9 o'clock and here's 3 o'clock. If you look closely, there is a white band crossing the cornea. This is called band keratopathy. But as I mentioned, this is actually a rather advanced case of band keratopathy. Early, if you send the patient to ophthalmology to be examined by our colleagues using a slit lamp, you will see this picture. This is another form of very early band keratopathy. You see, this is the illuminated arc of the slit lamp, and the white specks are the calcium deposits in the cornea. Okay? Is it clear? Am I going too fast? Just you tell me, please. Okay.
No, doctor, it's clear.
All right. Now coming to the investigations of hyperparathyroidism. You know very well by now that in endocrinology, we start off by doing the biochemical investigations, yani the blood tests, whether hormonal profile, etc. And then I'm not going to tell you about the laboratory investigations, because usually we do the serum calcium, the serum inorganic phosphorus, the alkaline phosphatase, and the serum PTH, parathyroid hormone. But I'm going to concentrate on the radiology because I know many of you have deficiency in reading radiology. And as I told you before, in the clinical exam next week, inshallah, one of the stations you will have is going to be about imaging. Okay, whether it is a plain X-ray of whatever organ, a CT or an MRI, or maybe also you may have a scintigraphy. Okay, so you need to be able to detect what type of investigation this is, and then what cut it is, if it is a CT or an MRI, yani coronal, axial, sagittal, using a dye or without a dye, contrast or without contrast, and regarding MRI, is it a T1 weighted image or a T2 weighted image? This, and in addition, you need to be able to detect the lesion. What is the pathology? What is the abnormality seen in this particular imaging? All right. So this is how you collect marks. But if you fail to mention any of the things I just mentioned, you have an incomplete answer, and so you will lose marks. All right. Of course, we're not talking about marks now. I know most of the students are, whether under or postgraduate, they are yani exam oriented, but this is a bad thing to do, because the worst exam we go through in our lives, in our careers as physicians, is that we are facing a patient that we are not able to diagnose or treat. Okay, this is the worst exam that we face. Okay, so back to hyperparathyroidism. Plain X-ray. Plain X-ray, as I'm going to review with you in a minute, it can show you generalized osteopenia or even osteoporosis. Okay, loss of lamina dura. Here I'm talking about the lamina dura of the teeth, not of the sella turcica. All right, subperiosteal bone erosions, bone cysts, and brown tumors, and I'm going to show you the difference between both of them. Osteitis fibrosa cystica. This is particularly seen in secondary hyperparathyroidism, commonly encountered in chronic renal failure patients, and calcification of soft tissues. So let me show you one by one. First of all, who can tell me, is there a difference between osteopenia and osteoporosis? Who can tell me? Is there a difference?
osteopenia البون mineral density بتبقى من -1 ل -2.5.
Yes.
ودي بري osteoporotic يعني والاوستيوبروتيك أكتر من أكتر من -2.5 بالدكسا سكيل.
Okay, very good. But in order to be able to distinguish, Dr. Maggie, these items, you need to do a DEXA scan, like you mentioned. But on plain X-ray, our colleagues in the radiology department, if they look at a plain X-ray of a bone, they won't be able to distinguish. They will tell you osteopenia. This is a radiological sign, right? Osteopenia is a radiological sign. So in order to probe further, if you find osteopenia on plain X-ray, you need to send the patient to do a DEXA scan in order to be able to distinguish between osteopenia and osteoporosis with the cutoff points that you mentioned, Dr. Maggie. Is it clear? Any problems so far? Okay, so let me show you the pictures. First of all, this is an intraoral periapical radiograph, the one that usually dentists do, okay? This is a normal one. On the left-hand side, this is the normal intraoral periapical radiograph. These are the teeth, all right? And you see the interlaced structure. This is the bone of the mandible, or of the bone of the maxilla or the mandible. This is the mandible, okay? You see, it's nicely structured as if it's woven, like a mesh. And if you look closely around the roots of each tooth, there is a white line. Can you see it? A very well demarcated white line. This is the lamina dura. Can you see it? Okay. Is it clear?
Yes.
All right. Now let me show you the picture on the right-hand side. This is an intraoral periapical radiograph of a patient with primary hyperparathyroidism. You see the teeth appear very dense, while the bone, the bone of the mandible, where is the mesh? It's lost. In addition, the lamina dura, the white line, as if it is erased. There is complete loss of lamina dura. Is that clear? Is the difference clear?
Yes.
Okay, great. Now let me show you, and this is another plain X-ray. You have to always explain, tell whoever you're talking to what this imaging technique is. So this is a plain X-ray of the left hand of a patient, okay, showing what? It shows subperiosteal bone resorption. This is also called acroosteolysis. That is lysis of the bone in the acral parts. Normally the terminal phalanges appear like they are rounded, but if you look closely here, they appear eroded. It's more evident here on the thumb. Can you see it? They appear eroded. Okay. And this is a plain X-ray of the right hand of the same patient, showing, in addition to the subperiosteal bone resorption or acroosteolysis, which is really extensive, it shows also what there is phalangeal tuft resorption. This is the phalangeal tuft resorption. I'm sorry. And this is the subperiosteal bone resorption. Normally, the periosteum appears like a white line, like the lamina dura I have shown you earlier, but here it appears eroded. It's erased. And not only that, but also the bone appears eroded. You see? Usually it appears more commonly in the index and middle fingers. Okay? And this is a plain X-ray of a child. AP view. How do I know it is a child? Who can tell me? Who can tell me?
not closer للإبيفيزيال.
Exactly, very good. The epiphyses are still open. You see here, the epiphyses are still open. So this is obviously a plain X-ray AP view of a child showing extensive subperiosteal bone resorption. Here, the bone resorption is in the radial and in the ulnar surfaces, aspects of the middle phalanx. In the previous X-ray, they were only seen in the index and middle fingers. Okay. All right. So this is before treatment. You see, there is phalangeal tuft resorption. It's eroded, as if it is eroded. This is the normal. It's like a small mushroom, okay? And here is you see this, the periosteum. It's white. But here you can see it is eroded. The white line is absent, and bone underneath is even eroded. I think in addition, there is osteopenia. Okay, the bone density appears much less. Is it clear? Is it obvious to you?
Yes, doctor.
Okay, fine. Now this is another sign, another important radiological sign. This is a plain X-ray of the skull in lateral view of a patient with primary hyperparathyroidism. This is a typical salt and pepper skull. If you put salt and pepper in a plate, what color will you obtain? The pepper appears black, right? While the salt appears white. This is the same picture here. So this is the skull vault. It appears also eroded, but the more important thing is there are black areas. These are the osteolytic areas, alternating with darker, whiter areas. These represent the salt and pepper. Okay, let me show you before and after treatment. So this is the picture, this typical salt and pepper skull that I have shown you earlier. And this is after treatment. This is the normal bone of the skull. This is how it looks like in plain X-ray lateral view. Is it clear? Any problems
Yes,
so
doctor.
far? All right. Now, let me show you. Earlier, I have shown you plain X-rays of the left and right hands of patients with primary hyperparathyroidism showing subperiosteal bone resorption. Again, here it is extensive. Yani not only the index and the middle finger, but also the ring and little fingers. You see, they are concave. Huh? Type. There is also phalangeal tuft resorption. You see here the terminal phalanx of the index finger appears to be missing, as if it is eroded, of the thumb as well, of the middle finger, the ring finger, and the little finger. There is generalized osteopenia, but if you look closely, the arrow points at this bone cyst or brown tumor. Now, what is there a difference between a bone cyst and a brown tumor? Can somebody tell me? What is the difference? Is there a difference between both a bone cyst and a brown tumor? This is a bone cyst. This is a plain X-ray of the left hand of a patient with primary hyperparathyroidism showing this is a bone cyst. You see, if you look closely inside it, as if the bone is taken out, okay? There are no internal structures, but in a brown tumor, like here, you see this is a plain X-ray of the left hip joint of a patient with primary hyperparathyroidism, AP view, showing this is the head of the femur, this is the neck of the femur, the greater trochanter, the lesser trochanter, and the start of the shaft. Of course, there is osteopenia. And here you see this is the pubic area, the pubic bone, okay? And here the arrow points at this expanded brown tumor in the inferior obturator ramus of the pelvic bone. If you look closely inside, it appears it has an eggshell appearance, as if there is bone resorption with attempts of new bone formation, but the new bone appears, it's not healthy. It appears defective. So this is what gives it the name brown tumor. Actually, the word tumor doesn't mean a malignant tumor. No, tumor means swelling. So it's swollen. This area is swollen, but of course it's covered with the muscles, so it's not obvious. But if the brown tumor occurs in the jaw, I will show you in a minute, it will cause expansion of the jaw. Okay, I will show you in a minute. But now let's shift to something called chondrocalcinosis of the knee. What is this? Yani, don't get scared of the long words. Subdivided into syllables. Chondro means chondrocytes, cartilage. Yani. Calcinosis, calcification. Now, let's see. This is a plain X-ray of the knee joint, but in close up. All right. We don't know if it's the right or the left knee. We don't have the indicator on the film. So actually you cannot see. So bone appears white. This is the lower end of the femur, and this is the lower end of the tibia. The upper end of the tibia. Can you see my cursor still? Okay, and these are the tibial tuberosities or tubercles. So inside the joint space, there is cartilage, right? Cartilage and synovial fluid. Cartilage usually appears dark gray or black in color. But if you look closely here, you will find a white line here, a white speck here, another white line here and there. So this means that this is calcium. This is the position of calcium inside the cartilage of the knee joints. So this is what is called chondrocalcinosis. Is it clear? Is the picture clear?
Yes, doctor.
Okay. Now coming to in hyperparathyroidism, there are different types. Primary, in which the disease is in the parathyroid glands themselves. Secondary hyperparathyroidism, this occurs due to hypocalcemia of whatever cause, may it be chronic renal failure leading to hypocalcemia, or osteomalacia or vitamin D deficiency, yani causing osteomalacia in adults and rickets in children. Or tertiary hyperparathyroidism. This is in cases of neglected, long-standing secondary hyperparathyroidism. Here, the parathyroid glands, they assume autonomous secretion away from the feedback mechanisms between calcium and PTH. Okay? Type. Let me discuss. In secondary hyperparathyroidism, they have particular plain X-ray pictures, like for instance in osteomalacia. Okay, you will. This is a plain X-ray of the right hip joint. Okay, of a patient with secondary hyperparathyroidism, showing this is the acetabulum and this is the head of the femur. This is the neck of the femur, the greater trochanter, the lesser trochanter. Of course, this is a close-up. The arrow points at something that appears to be a fissure fracture, but this is not the case. This is what we call Looser's zones, a typical radiological finding in secondary hyperparathyroidism. Okay? Not only that, but in another type of metabolic bone disease that is encountered in chronic renal failure patients, we can find osteosclerosis. That, as the name implies, there is excessive calcification of the bone. So the bone appears more sclerotic than usual. More sclerotic means on a plain X-ray whiter than normal. So this is a plain X-ray of the lumbar spine of a patient with secondary hyperparathyroidism, showing what is called Ruger Jersey spine. What does this mean? You see, the white areas are the vertebrae, the lumbar vertebrae, okay? The black areas in between are the intervertebral discs. So this appears like the jersey of, for instance, jockey player or soccer players. In the past, they used to wear these jerseys that are striped, white and black, or red and black, and or red and white, and so on. Not like nowadays they wear, for instance, Vodafone or Coca-Cola. Okay, so it appears, it is similar. The spine, the lumbar spine, appears similar to the rugged jersey of those players. Okay, so this is why it is called Ruger Jersey spine, typical for osteosclerosis. Okay, is it clear?
دكتور هو ده
نعم.
هو ده ليه اختصار تاني اسمه ديش؟
لا لا، ديش حاجة تانية. ديش حاجة تانية. Okay. طيب. Okay, let me show you again in secondary hyperparathyroidism. Those of you who are working in nephrology, you may have noticed that patients with chronic renal failure, they may have a waddling gait. Did you notice? The waddling, يعني بيمشي زي البطة كده. Did you notice that ولا لا؟ ها؟ Did you notice the waddling gait in patients with renal failure, chronic renal failure?
No.
Anyway, يعني if you get the chance and see a patient, try to look at the gait. This waddling gait may occur due to two reasons. First of all, there is proximal myopathy. Proximal myopathy affecting, I told you last time, the time before, and the pelvic girdle muscles. In that context, it affects the gluteus. So they have a Trendelenburg gait. Okay. Usually whenever we raise our lower limb, the pelvis on that side will be elevated by the glutei, but since they have weakness of those muscles, the pelvis drops. So this is why this waddling occurs. Not only that, but also because they have widening of the sacroiliac joint. So this is a plain X-ray of the sacroiliac joint of a patient with secondary hyperparathyroidism showing excessively widened sacroiliac joint on both sides. So this causes instability of the pelvis. So it doesn't only have a muscular element, but also a joint element. Is it clear? Normally, the sacroiliac joint should be just a line, visible like a whitish line. Yeah. But here it is excessively white. Is it clear?
Yes, doctor.
All right. Now, patients with primary hyperparathyroidism, they tend to suffer from pathological fractures. As the name implies, pathological means that it occurs in unhealthy or pathological bone. They tend to occur with trivial trauma. The patient will tell you, I just tripped over the carpet and I suffered a fracture. Is that significant to cause fracture neck femur, like here? Of course not. Huh? Or even fracture of the shaft of the femur, like I'm going to show you in the next slide. So this is a plain X-ray of the right hip joint of a patient. And this is the acetabulum again. This is the head of the femur. Where is the neck? It's compressed because there is an intertrochanteric fracture. This is the greater trochanter and the lesser trochanter and the shaft. You can see there is extensive osteopenia, you see? So the patient suffered a pathological fracture, all right? Now, this is another pathological fracture. You see, this is a plain X-ray of the left femur, L. We can see L. So this is the left femur. Here is the head, the neck, greater trochanter, lesser trochanter. This is the shaft. There is a lesion here and another lesion there. So there is a well-marginated cortical lytic lesion. If you look closely inside, you will find there is endosteal scalloping, as if there are structures inside. Okay, this is a brown tumor. The patient had another brown tumor, more proximal, and he or she, I don't know if it's a male or a female patient. They fractured. They suffered a fracture in the proximal lesion. Okay, and this is after healing. This is callus. You remember the callus? How this is that we studied in the pathology a long time ago. This is how a fracture heals, but unfortunately, the brown tumor that is still seen distally with the endosteal scalloping, that's very obvious here, okay, is still there. So if this patient is unlucky, he or she are going to suffer from another pathological fracture here. Is it clear? So this is a brown tumor, okay? Is it clear? Again, this is the fracture, the pathological fracture through the proximal brown tumor, and here after healing with callus, but the distal brown tumor is still there. Okay. Now coming, any problems so far? Am I going too fast?
No.
Okay. Now nephrocalcinosis. Nephrocalcinosis. From the term nephro, kidney, calcinosis, calcium. This is what, who can tell me? This is a plain X-ray of the kidneys and urinary bladder, but here it concentrates on the kidneys. You see the ribs, okay, the ribs, and this is the area of the renal angle between the last rib. Can you see my cursor? Shall I put it as a laser pointer better? You see, this is the last rib, okay, the last rib, and here is the shadow of the psoas muscle. So this is the renal angle. This is the shadow of the kidney, okay? Here is the shadow of the kidney. Can you see it? If you look closely inside, you will find white specks. What are these white specks? These are calcifications inside the kidney. Now let me show you. These are not renal stones. And I will show you in the ultrasound the difference between the nephrocalcinosis and renal stones, how they look like. Okay, so this is an ultrasound picture of one of the kidneys, most probably the right, because you see I will explain to you the ultrasound. This is anterior, this is posterior. And why does it appear conical like that? Because the transducer is placed on the anterior abdominal wall of the patient here, and the rays, they are dispersed like that. So they give a conical picture like that, okay? So this is the diaphragm, the white area. So this is the liver, okay? And this is the right kidney. It's cut longitudinal. You can see the cortex and the medulla. Right. If you look closely, there are here some shadows. Can you see? Black areas. These black areas are called acoustic shadow. Why? Acoustic from sound, yani, because the ultrasound is a type of sound. We don't hear it, but it is a sound. So when sound waves pass through the different structures of the abdomen, they produce some of the rays are reflected back to the transducer, and others are pass through the structure, giving the picture that we see. But suppose, imagine you are in plain summer at 12 noon under the sun, and you are holding an umbrella. If you look at the below you on the floor, on the ground, you will find a shadow, right? Why? Because the sun rays are obstructed by the umbrella. The same principle applies here. Here there are you see the renal medulla, or the pelvic calyceal system. It shows, actually it's in the pyramids. The pyramids are calcified. So the calcium acts like a barrier preventing the passage of ultrasound waves. So this is why acoustic shadows are produced. Is it clear? Is the mechanism clear?
Yes, doctor.
Okay, this is another very clear picture. You see, this is the typical ultrasound picture of the liver. So here, actually, in every ultrasound, in order for you to know whether it is transverse or longitudinal, there should be a key like here. So here is the arrow points at the transducer. So this is a longitudinal cut of the right kidney. Why right? Because this is the liver. The portal tracts are visible. And again, the pyramids are calcified. You see the white structures. But here the acoustic shadows are not obvious. But what about, here is another example for nephrocalcinosis, a transabdominal ultrasound. You see, the white arrows point at these pyramidal structures behind which we have acoustic shadows. These hyperechoic structures are the pyramids. The pyramids, remember? The pelvic calyceal system is like that. And in between are the calyces are the pyramids of the middle. You remember the anatomy? So this is how they look like. They are white in color because they are calcified, and behind them there is an acoustic shadow because the calcium prevents passage of ultrasound waves. Is it clear? But ultrasound of the abdomen doesn't only show nephrocalcinosis, it can also show many renal stones, like here. Now, the renal stones are inside the pelvic calyceal system, not outside, like the pyramids, the calcified pyramids, you see? And obviously, they are denser. You see this white structure is a stone, and behind it is a marked acoustic shadow. Here's another stone. And here are some smaller stones with acoustic shadows. All right? We use also ultrasound to diagnose, to check the neck, or to look at the neck of the patient with hyperparathyroidism. Why? Because usually normal parathyroid glands, they are not visible on neck ultrasound. When they are visible, this means that they are enlarged. All right, so this is ultrasonography of the neck. Remember the ultrasound of the thyroid that I have shown you last time? In the midline, we have the trachea, this white shadow. In front of it is the isthmus. This is the right lobe, and this is the left lobe of the thyroid. And the arrows point at an inhomogeneous. You see this, the structure or the texture is not homogeneous, and the echogenicity is not homogeneous. Here's a black area. Here's a somewhat hypoechoic area. Here's some a somewhat hyperechoic area. This is an enlarged parathyroid gland. All right. This is another neck ultrasound showing, again, this is the trachea, and this is the left lobe of the thyroid gland. This is the carotid artery, and this is a hypoechogenic oval structure behind the left thyroid lobe, representing one of the parathyroid glands. And again, on close up, this is how it looks like. It's hypoechoic. Okay, is it clear? Sorry, but actually, ultrasound of the neck is not very sensitive. It's safe because it doesn't expose the patient to ionizing radiation, but it's not a very sensitive technique for detection of parathyroid adenomas, right? So we can do CT scan. Remember when I told you we can look for brown tumors in the jaw? This is a CT scan of a patient with primary or secondary maybe hyperparathyroidism. Show this is a coronal cut. It's cut like that along the coronal suture. Okay, so let me show you the anatomy. Of course, here they didn't use any contrast. Bone appears white, so this is the bone of the middle cranial fossa. Here are the teeth, okay, and here the orbits appear. Here is the nasal septum. The nasal turbinates appear very nicely, and air appears black. So this is air in the nose. And here the maxillary sinus, you see, is filled with like fluid. Yani maybe this patient has maxillary sinusitis. Here the orbits started to be visible. And here you can see there is an expanded bony lesion in the jaw on the right side. On the right side. Okay, R4 right. But if you look closely inside it, you will find again the eggshell appearance. You see, there are attempts at new bone formation, but this new bone is pathological, or of course, deforming the teeth as well. Okay, and here is the whole of the brown tumor. Okay, is it clear? The other name for a brown tumor of the jaw is osteoclastoma. Osteoclastoma of the jaw. Is it clear? Type. What else can we see with the CT scan? We can do a CT, an axial CT of the neck. Here the cut is like that. Let me show you the anatomy. Here is anterior, here is posterior, here's right, and here's left. Type. What is this? Air. Air is present in which structure in the neck? Who can tell me?
Trachea.
Exactly, the trachea. Type. This structure in front of it, this is the isthmus, this is the right thyroid lobe, this is the left thyroid lobe, okay? Top, what is and this is the vertebra, the cervical vertebra. White because it is bone, full of calcium. Top, you see an arrowhead here. It is pointing at what? This is a parathyroid adenoma in the right perithyroidal region, okay? So this is axial CT of the neck showing this. Type. Again, what I didn't tell you earlier is that parathyroid glands can be aberrant. Yani they can occur in ectopic sites. One of these sites is where? In the anterior mediastinum of the chest. So this is an enhanced CT of the chest. Enhanced means that the patient was given intravenous contrast. How do I know? Because let me review the anatomy. The patient, this is anterior, this is posterior, this is right, this is left. Okay, bone appears white, so this is the thoracic vertebra, and these are the ribs here and there, and this is part of the scapula. Okay, the left scapula and the right scapula. Type. What is this structure that appears white in color? What is this structure? Who can tell me?
Aorta.
Exactly, very good. The ascending aorta, the arch, and the descending aorta. Why is it so white? Because the patient was given intravenous contrast. And the lungs, of course, are black because they are full of air. But here, you see the intravenous contrast started to fill the vascular markings of the lung. This is why they started to appear white like that. Okay, so what is this structure here? You see, there is something here. What is this? You can tell. Can you see it? This structure here. What is this? There is a lumen surrounded by a thick wall. What is this? What could this be? Related to the aorta, to the descending aorta. What structure is that? Who remembers the anatomy? The esophagus, يا جماعة. The esophagus. This is the esophagus. Okay. طب what is the arrow pointing at? This is a rounded structure. Most probably an ectopic parathyroid adenoma in the anterior mediastinum, in the anterior part of the superior mediastinum. This is very important because you see, whenever you have a patient with high primary hyperparathyroidism, and you send the patient for surgery, our colleagues, the surgeon, they usually don't do surgery for the patient unless they look for other potential ectopic parathyroid glands in the patient's body, because suppose the patient has multiple parathyroid adenomas, one of them in the neck and the other ectopic, and the surgeon just dissects the neck and removes the parathyroid adenoma in the neck, okay, but leaving the parathyroid adenoma in the superior mediastinum. The patient's symptoms and signs won't resolve, you see? So this is why it is very, very, very important to exclude presence of ectopic parathyroid adenoma elsewhere before sending the patient to surgery. Is it clear? Did you see any parathyroid cases during your rotation in endocrinology? Can you still hear me?
Yes, doctor. No, we haven't seen.
Okay, fine. Anyway, now MRI, magnetic resonance imaging, can you use it to detect hyperparathyroidism? Yes, of course, particularly the ectopic, the ectopic parathyroid adenomas. You see? Now, let me show you. This is an unenhanced, yani this is an MRI of the, is that the neck or the upper mediastinum? What do you think? What do you think? Where is the thyroid? Here we can see only the trachea, but where is the thyroid? So we are at a lower level, right? So we have to be in the superior mediastinum, because if it were in the neck, you would have seen the thyroid as well. But here we are at a lower level. So most probably this is an MRI, okay, of the upper chest type. Is it T1 weighted or T1 weighted? Who can tell me? It's T1 weighted, not because it's written here, but because the CSF appears black. This is the vertebra, and so this is anterior, this is posterior, this is right, this is left, and here the CSF appears black. So this is obviously T1 weighted magnetic resonance imaging without any contrast, okay, showing what? The arrow points at this mass, which is compressing the esophagus. You see? So this is most probably an ectopic parathyroid adenoma present in the paraesophageal tracheoesophageal tract. It's lower down than the earlier case that I have shown you. And this is how the T2 weighted image appears. And of course, it's axial because it's cut like that, okay? Axial. Type, yani, you remember the mass that appeared somewhat gray in color in T1 weighted image appeared now whitish in color, more white in color in the T2 weighted and images. And here you see the CSF turned white, okay? So this is an iso-intense ectopic adenoma in the paraesophageal or tracheoesophageal tract. Again, an ectopic parathyroid adenoma, okay? But the best imaging technique, or one of the best, because nowadays we have something called 4-dimensional CT of the parathyroid glands, but I didn't include any pictures actually because it's a bit complex to explain. and I'm not a radiologist, obviously. So I'm just going to explain to you this technetium-99 sestamibi scan. Now, what is this complicated word? Technetium-99 is the radioisotope, okay? Sestamibi, this is a type of protein carrier that carries this radioactive isotope. Now, what is this scan? It can be colored like on this picture. Usually the technetium-99 is taken up by the salivary glands, by the thyroid gland, and by the parathyroid gland. But remember, this picture appears similar to the pictures I have shown you last time in thyroid scintigraphy. Remember, this is the thyroid. See, the right lobe and the left lobe. And these structures are what? Who can tell me? Can you see the cursor? These structures are what? This is the head, this is the neck, and this is the upper mediastinum. Who can tell me? These structures, what structures are those that take up the technetium-99 sestamibi?
Salivary glands.
Exactly, which one? Which, yani, specify, please. They are here. Which area is this?
Submandibular.
Exactly, the submandibular salivary glands. Now, the technetium-99 is taken up by the submandibular salivary glands, by the thyroid, you see? But here, there is a marked uptake at which the arrow is pointing. This is most probably an adenoma, a parathyroid adenoma below the inferior pole of the left lobe of the thyroid gland. So this is most probably a left inferior parathyroid adenoma. Usually, when detecting, trying to localize a parathyroid adenoma, they use delayed scans, yani not immediate, because the immediate scans, they can show as mentioned, the salivary glands and the thyroid. So it may be confusing, okay? But if you, like here you see, this is early. You can see even the parotid gland. Here's the parotid, part of the parotid, the thyroid lobe, the right, the left, and this is the inferior, the left inferior parathyroid adenoma, okay? But here, this is in contrast, this is to show you the thyroid. Where did the parathyroid go? The parathyroid is not seen. This is the difference. But here is the delayed film. You see, everything has disappeared. The radio tracer, I mean, has disappeared from the salivary and the thyroid glands, leaving only the left inferior parathyroid gland. Is it clear? So it may be colored like here, like the previous picture, or it may be black and white like here. And this is to show you, remember the picture where I showed you the enhanced CT chest? This is the same patient, a technetium-99 sestamibi scan, a delayed image, again, because nothing's seen in the neck any longer, you see. But here you can see increased radiotracer uptake in the mediastinum, and when surgically removed, it was proven to be an ectopic parathyroid adenoma in the superior mediastinum. Is it clear? Any problem so far? Am I going too fast?
No, doctor. تمام.
Okay, fine. Type. So, in order to diagnose ectopic parathyroid adenomas, you can either do an enhanced CT chest like here, the picture I've shown you earlier, but better, you should do a technetium-99 sestamibi scan, or even nowadays a 4-dimensional CT. Okay? So far, any problems? Any
دكتور منى يعني
tell me.
التكنيشيوم 99 ده is done before any parathyroid surgery should be done.
Yes. Okay. Okay, fine. But nowadays, you see, because many patients, it's expensive, relatively expensive, and not readily available. So the radio tracer, I mean, and some patients are don't like to be exposed to radioactive material and so on. So nowadays they have, since a couple of years, they have proven that 4-dimensional CT is even better than technetium-99 sestamibi scan. But either way, you need to exclude before sending your patient to surgery with your patient with primary hyperparathyroidism to surgery, you need to exclude that he or she, they have ectopic parathyroid tissue in the mediastinum. Okay? This is the message
Okay.
I want you to get, Yani. Is it clear?
Yes.
All right, great. Now coming, do you want to break or shall I continue? You tell me.
We can continue.
Okay. Now, coming to hypoparathyroidism. There are two clinical types of hypoparathyroidism. The acute type, which presents with overt tetany. I'm going to show you a picture of a patient with tetany. Or chronic hypoparathyroidism. This is what it's characterized by latent tetany. Yani it's not readily apparent. You need to do some maneuvers that I'm going to tell you about in order to elicit tetany. And it's usually associated with ectodermal and CNS changes. All right? So acute hypoparathyroidism, in this type, the patient presents with paresthesia, abnormal sensation, numbness around the mouth and in the extremities. Okay, muscle spasms, particularly in the hands and feet. These are what cause the tetany. Even spasm of the laryngeal muscles, and this can lead to stridor and death. The patient may suffocate. Not only that, but the patient can also suffer from tonic-clonic spasms that lead to convulsions. Okay, but they are not convulsions. It's better to call them epileptiform convulsions, because I will tell you how to distinguish between the tonic-clonic spasms that occur in acute hypoparathyroidism and the convulsions that occur in grand mal epilepsy. Does anybody know the difference, how to differentiate between them? Can anybody tell me?
I think in the convulsions مع epilepsy بيكون في ممكن urinary incontinence.
Yes, very
بيكون
good.
في
What else?
بيكون في aura.
Exactly, there is an aura before, yani the patient feels abnormal sensation, either auditory, visual, whatever, before getting the fit. And then during the fit, the patient is incontinent. He or she, they may injure themselves. For instance, if a housewife is cooking in front of a burning fire in front of the stove, she may fall over the stove. Yeah, she can hurt herself, and she may bite the tongue. Okay, and then following the fit, the grand mal epilepsy, the patient usually goes into deep sleep. But in epileptiform convulsions, those found in acute hypoparathyroidism, the patient is actually conscious during the fit. He doesn't lose consciousness, and he's continent. He doesn't injure himself. And after the convulsion passes, he doesn't pass into deep sleep like in grand mal epilepsy. This is very important. You see, just by taking proper history from a patient, you are able to distinguish between grand mal epilepsy and acute hypoparathyroidism. Because actually, a long time ago, we have seen a young patient. He was 16 or 17 years old. He was referred to Nariman Hospital, the neurology department, for treatment of grand mal epilepsy. But actually, it turned out he has hypoparathyroidism, and this caused hypocalcemia, and this is what caused the fits. Okay. Type. Another interesting case I have seen before, Bordeaux, during my residency, was a male 45-year-old patient. He was bilaterally blind. He had a bilateral cataract, okay? And he had a tracheostomy tube in place. Now, what is this? He came presenting with dyspnea and wheezy chest. He was a heavy smoker, and he had an acute exacerbation of chronic obstructive pulmonary disease. When we were trying to measure the blood pressure, the patient developed carpal spasm. Oh, what is this? It turns out, very interesting presentation. It turns out this patient, a long time ago, he became blind, and then he suffered from stridor. Why? Because of laryngeal muscle spasm. So he was brought to the ENT department where he had the tracheostomy tube, but nobody searched for the actual cause of the laryngeal, of the stridor, and of the blindness. So we checked the serum calcium. It was very low, 4, and the PTH was very low. So it turns out this patient had hypoparathyroidism, and this is what caused the cataract and the stridor, and this was the cause of the insertion of the tracheostomy tube. Imagine the patient lived years and years with the tracheostomy intact, and nobody bothered to only symptomatic treatment. This is very wrong. You need to go behind the cause. What caused the stridor, you see, and treat this. So actually, we checked the serum calcium. We found it low. We treated the patient until his hypocalcemia was controlled. Then we sent him to our colleagues in the ophthalmology department. He had one cataract taken out, and then the next month he had the second cataract taken out, and he became a seeing person again. And he was very happy about that. You see, so always don't treat the patient symptomatically. Go behind the cause of the symptoms in order to be able to treat him or her correctly. So chronic hypoparathyroidism, as I mentioned, presents with latent tetany. This is revealed by doing special signs or looking for special signs, namely Schwostek's and Trousseau's signs. I'm going to show you in a minute what they are. And the next thing you look for are ectodermal changes like dry, scaly skin, brittle and sparse hair. You see, in common with hypothyroidism, but you have to have a high index of suspicion. Ridged nails with white patches, lens opacity, like the patient I just told you about, and abnormalities of the teeth as well. And the CNS changes include mental abnormalities, convulsions, but better epileptiform attacks or fits, and papilledema. Okay. Now, let me explain to you what Schwostek's sign is. Schwostek's sign, you need to do it. How do you do it? You tell the patient to open the mouth halfway, and then you start tapping with the middle finger, okay, in front of the tragus of the ear or midway between the tragus and the angle of the mouth. Normally, in all of us, if you do it, you see, I'm doing it myself, on myself. Can you see my picture? Yani nothing happens. But if you do it, like I'm going to show you in the video, if you do it on a patient with latent tetany, he or she, they will develop twitching and around the angle of the mouth up to hemifacial spasm, depending on the severity of hypocalcemia. Okay, this is Schwostek's sign. Now let me show you the video. Am I going too fast? Huh?
No, doctor.
لا يا دكتور.
Okay, sorry. Let me open the video first. Just tell me when you see the video, please. Can you see the video now?
Yes.
Huh? Okay.
لا يا دكتور.
Now, watch carefully. These are the physician's hands. Okay. You see, he's trying to tap over the area where in front of the tragus of the patient's ear. Now look closely at around the angle of the mouth. What happens? Okay. You see the twitches? Is it visible?
Yes.
Okay. So look at the other side. The other side is even clearer, Yani. You see? Very obvious. Is it clear? You want to see the video again?
لا تمام يا دكتور واضحة.
طيب. Oh, okay, fine. خلاص يبقى this is Schwostek's sign. تمام? طيب, now Trousseau's sign. Can you see my slides? No, cannot. Let me share the slides again. Can you see my slides?
Yes.
Yes.
Yes, okay. So this is Trousseau's sign. Trousseau's sign, you need first to measure the blood pressure of the patient to elicit or to detect where the systolic blood pressure is. Why? Because the next thing you do is, suppose you measure the blood pressure of the patient, you find it to be 120/80. So the next thing you do is you inflate the cuff of the sphygmomanometer to 130, yani 10 millimeters above the systolic blood pressure. And you maintain this for 3 minutes. I know this is, you will tell me this is torture. This is very painful. Of course it is painful, but you tell the patient, you assure the patient, please bear with me because this is a very important sign I need to check. خلاص? Type. Why do you have to wait for 3 minutes? Because if after 3 minutes nothing happens, the test is negative. But suppose there is very mild hypocalcemia. It may, this sign may be obtained after 2.5 minutes. Okay? So if you do it for just half a minute and nothing happens, you will say it's negative, but it's a false negative. Do you understand what I'm saying? So you have to wait for the whole 3 minutes. If nothing happens, then the test is negative. So what happens in Trousseau sign is that, like I'm going to show you in the video, flexion of the thumb will occur, followed by a flexion of the extended fingers, then ulnar deviation of the fingers, flexion of the wrist and elbows. Okay? Is it clear? I will show you now. So here is the patient's hand, and the physician is measuring the blood pressure to see the systolic blood pressure. And here he raised the pressure inside the sphygmomanometer cuff to 10 millimeters above the systolic blood pressure and waited. You see, this is the Trousseau sign. Carpal spasm occurred. This is a positive Trousseau sign. Okay, so now let me show you the video. In the video, it's even clearer. Yeah. Okay. Let me open the video first. Is it difficult for you to understand, or is it okay? Huh?
It's okay, doctor.
Sorry, let me share the video. Please tell me when you see the video. Can you see the video now?
Yes.
Okay, let me play it from the start. So you see, the blood pressure was measured. You ask the patient while doing the Trousseau sign to keep the palm extended. I mean, the fingers and the thumb extended. See, the first response is flexion of the thumb. Okay, and then flexion of the extended fingers. You see, and then they start to deviate towards the ulnar side, and now the wrist starts to flex. You see. Of course, we don't wait until all this happens because it's very painful for the patient. Here, it's just for teaching purposes. Yani they have waited till the very end to show the students how Trousseau sign develops or how carpal spasm develops. You want to see the video again, or is it clear?
Yeah, it's clear.
But usually, you see the patient I was telling you about, the one with the tracheostomy in place. Once we yani, as soon as we inflated the sphygmomanometer cuff, his carpal spasm occurred. As soon, yani, within a matter of few seconds, you see. This is why we diagnosed him as having Trousseau sign positive. So he has to have a hypocalcemia. Is it clear? Now, let me go back to my slides. Am I going too fast? Huh?
لا يا دكتور تمام.
Okay, can you see my slides? Are they in slideshow? This is
Yes.
tetany. You see, tetany, it occurred spontaneously without any sphygmomanometer cuff in place. The patient came presenting with carpopedal spasm. The same occurs in the feet, but here we have shown only the carpal spasm. Okay, right. Now, coming to the investigations of hypoparathyroidism, here you do the lab investigations. You will find here it is preferred to do an ionized serum calcium, ionized. Low serum ionized calcium, and you will find low 24 hours urinary calcium excretion, high serum phosphate, and low PTH. Quite the opposite of what you find in hyperparathyroidism. In hyperparathyroidism, you find high serum calcium. You can find hypercalciuria, yani increased calcium excretion in urine, you will find low serum phosphate and high PTH level. But here, in hypoparathyroidism, the alkaline phosphatase is normal, while in hyperparathyroidism, the alkaline phosphatase is high. Who can tell me why? Is there an explanation for this?
Due to resorption of the bone.
So what? The resorption of bone causes what? Who answered? Dr. Mariam? Yes.
Yes.
Yeah. Why does bone resorption increase alkaline phosphatase? Alkaline phosphatase is secreted from which cell in the bone? From which cell? From which cell, يا جماعة? The long silences again. From which cell? Yeah, if you don't know, just tell me. I don't know. But don't keep quiet. Yani we're just losing time, nothing more.
I don't know صراحة doctor.
طيب, you don't know. Thank you for being honest. طيب. Now, bone resorption occurs by which cells type? What are the
osteoclasts?
Osteo? Say again, please.
Osteoclasts.
Exactly, osteoclasts. Eat the bone. Type. Bone is a dynamic structure. يعني it's not like cement كده ولا زي الحيطة ولا بتاع. لا. Once there is bone resorption, bone formation starts. Both of them should be in equilibrium, right? طب what are the bone forming cells? What are they called? نعم. I didn't hear you, دكتورة ماجي. Osteoblasts, exactly. Osteoblasts. These are the cells that secrete the alkaline phosphatase. You see? Type. Why is alkaline phosphatase high in hyperparathyroidism? Because bone resorption is followed by bone formation. Remember the brown tumors? So this is why there is a high osteoblastic activity. This is the reason for a high alkaline phosphatase level. But here in hypoparathyroidism, nothing is wrong. The problem is that PTH is low, so the serum calcium is low. There is nothing wrong with the bone. Do you understand? So this is why alkaline phosphatase is normal. Is it clear? Does it make sense? Okay, great. Now, if we do radiological investigations, here you can do a CT on the brain. You will find calcification of basal ganglia, like on this picture. You see, this is an axial CT brain without contrast, without. The bone appears white. This is, can you see my cursor? Let me transform it into a laser pointer. You see, this is bone. It appears white. In CT, without contrast, the structures that appear white are the following: bone, hemorrhage, or calcifications. These structures are what? These are the basal ganglia. Obviously, if you look at the CT without a history, you won't be able to determine whether this patient has hemorrhage or not, because يعني صعب يبقى فيه bilateral hemorrhage، صح؟ إنما ممكن يبقى فيه ايه bilateral calcifications. So this was a patient with hypoparathyroidism, and for some reason or another he did a CT on the brain and it showed bilateral basal ganglia calcification. They have, you see, they have exactly the same density as bone due to high calcium content. Is it clear? And we see this a lot among our hypoparathyroid patients. Okay, now coming to the conditions that mimic hypoparathyroidism, شبههم يعني. We have two conditions. One is called pseudo hypoparathyroidism. Whenever you read this word pseudo, this is Greek for false. So this is a false hypoparathyroidism. I will tell you in a minute why it is false. And we have another condition, important condition called pseudo. What is this? A false pseudo-hypoparathyroidism. What is this? I will show you in a minute. Now, pseudo-hypoparathyroidism, they are several clinical disorders. They are characterized by end organ resistance to PTH. يعني حاجة كده شبه الانسولين resistance بس regarding the PTH. Okay? And they have been collectively described by the term pseudo-hypoparathyroidism. How do such patients look like? Now, what do they have? Actually, they are hypocalcemic, like in hypoparathyroidism. They are hyperphosphatemic, like in hypoparathyroidism. But in the normal hypoparathyroidism, the PTH was what? It was low, remember? Here, the circulating PTH is high. Why? Because there is PTH resistance. Okay? Now, what is diagnostic is that there is target tissue unresponsiveness to PTH. And this is manifested by what? If you check cyclic AMP excretion in urine in response to parathyroid administration, you will find there will be no increase in cyclic AMP as occurs normally. Yani in all of us, if you, for instance, take me, I'm normal, خلاص? If you measure my PTH, you will find it to be normal. And then if you give me PTH by injection, خلاص? And you measure my cyclic AMP in urine, you will find that it is elevated. خلاص? It will become higher than basal. But in pseudo hypoparathyroidism, this doesn't occur. Okay? Now, how is it clear? Is it clear?
Yes.
Great. How does the patient look like? Actually, this is a young lady. In this picture, this is a young lady. She's not a child. She is short. She is around the 3rd percentile. She has disproportionate shortening of the limbs. Remember? Can you see? The span is less than the height. Normally, both should be equal. She has generalized obesity with a rounded, flat face, and she is also mentally subnormal. If you look at her hand, you see this is the hand of this lady. She has something called brachydactyly. What does this mean? She has shortened 4th and 5th fingers with a slightly foreshortened terminal first digit, which is very short, and a wide thumbnail. This is what it is called potter's thumb. يعني زي الناس اللي بيشتغلوا في الفخار صباعهم الثumb ده بيتاكل يعني من كتر. Okay. طب if you ask the patient to do a fist, can you please do a fist? Can you see my fist? Show you. Can you see my fist? When I'm doing a fist, you see my knuckles?
Yes.
Are they visible? Look at this lady's fist. Can you see the slides? You see? She made a fist, but instead of the knuckles being apparent, there are dimples. حفرات كده حفر. Where did the knuckles go? Of course, she has short 4th and 5th metacarpal bones as well. So instead of the heads being here, they became shorter. So instead of the head, there is a pit or a dimple. So this is an important sign called Archibald sign. And no need to remember the sign, but at least there are characteristic dimples in place of the knuckles. Okay? So again, this is the hand of the lady showing brachydactyly with short 4th and 5th digits. And this is the plain X-ray of this hand. You see, she has not only short 4th and 5th fingers, but also shortened 4th and 5th metacarpal bones. Is that clear? This is what is found in pseudo-hypoparathyroidism. Now, what you can see in pseudo-hypoparathyroidism, this picture, this is a plain X-ray of the right hand of a lady. You see she's wearing a nice ring, showing the same picture. She has short 4th and 5th fingers with short 4th and 5th metacarpal bones. But if you examine the patient's external appearance, she doesn't have and this short stature, the obesity, the rounded, flattened face, the mental subnormality, and she has even normal serum calcium, phosphorus, and alkaline phosphatase. So this means that in pseudo hypoparathyroidism, this term describes only the phenotypic defects, the appearance, the external appearance, but without any abnormalities of calcium metabolism. Is it clear?
Yes,
Is it
doctor.
clear? Great. Okay, so this is the conclusion of the session, the revision session on parathyroid diseases. Do you want to continue the adrenals or shall we call it a day? You tell me. You tell
Yes,
me. Huh?
I
Sorry?
would like to continue with the adrenal.
Only Dr. Mariam. What about the rest of you?
ممكن نكمل يا دكتور؟
ممكن نكمل. طب عايزين بريك تروحوا تشربوا حاجة تاكلوا حاجة تمشوا رجليكم عشان تصحصحوا كده. الادرينال فيها كلام، فيها كلام كتير يعني. وبعدين الصور بتاعت الادرينال مهمة للسي تيز اي مين الايمجينج. فتحبوا ناخد بريك كده 5 دقايق او لحد 7 دقايق يعني. ناخد بريك كده نتمشى شوية بس عشان من كتر القعدة. اوكي we'll come back at 9.
Okay.
ماشي.
اوكي يا دكتور.
all right
أوكي.
great thank you. Are we back? Can you hear me?
Yes, doctor. Yes.
One more minute to go. Shall I wait? Can you see my slides?
Yes, أيوة يا دكتور شايفين.
طيب. Small ولا in slideshow?
لا in slide show.
Moving or fixed?
Moving يا دكتور.
Great. So this was supposed to be the 4th revision session, but يعني, considering that you have exams and you requested that we do it today, I'm going to revise today the following intended learning outcomes. Let me check the slideshow setup. Okay, so the intended learning outcomes of this session is that by the end of today's session, you will be able to list the symptoms and signs of Cushing's syndrome. And I understand you have seen a patient already, right? Did you see a patient of Cushing?
Yes, doctor.
Okay. Was it a male or a female? Huh? Male or female?
A male.
A male. Done. Okay. And then you're going to be able to understand the various imaging modalities, again, in Cushing syndrome, namely MRI of the pituitary gland if it is Cushing's disease, CT adrenal glands if it is due to an adrenal adenoma or carcinoma, and octrio scan. This is a particular form of imaging I'm going to tell you about that can detect ectopic Cushing syndrome. Okay? And you're going to be able to list the symptoms and signs of Addison's disease. Did you see any cases? Huh?
لا.
Right. Understand the various imaging modalities in Addison's disease, again, in terms of plain X-ray of the kidneys and CT adrenal glands. You're going to be able to list the clinical manifestations of pheochromocytoma. Did you see any pheochromocytoma cases?
لا يا دكتور.
Sorry. Understand the various imaging modalities in pheochromocytoma, namely, again, CT adrenal glands, MRI of the adrenal glands. Now, this is called iodine, MIBG scan, met-iodobenz-guanidine scan, and the very sensitive but very expensive MIBG SPECT CT fusion scan. يعني ما نتخضش من المسميات لما نفهمها ونشوف الصور. يعني you're going to be able to understand what it means. These are again scintigraphies يعني. خلاص؟ ماشي؟ You're going to be able to list the clinical manifestations of Conn's disease. Did you see any cases?
لا يا دكتور.
Right. Enumerate the biochemical investigations of Conn's disease, and you're going to be able to understand the various imaging modalities in Conn's disease, namely CT adrenals, and here again the scintigraphy, but using radioactive iodonorcholesterol scan. All right? Let me start by Cushing's syndrome. Here on this diagram, you can see the clinical manifestations of Cushing's syndrome. Usually it is a lady, a female patient, okay, complaining of emotional disturbances or depression. She has moon faces. She has a buffalo hump. I will show you how it looks like. أتب كده. She has truncal obesity. يعني the thorax and the abdomen, they look obese, but the limbs are thin. Okay. The skin is thin, wrinkled, and there may be some skin ulcers with poor wound healing or purpura and bruising. And of course, the abdominal stria rubra. Okay. Of course, the patient has also muscle weakness, again proximal, affecting the pelvic and shoulder girdle muscles. Okay, and the patient may develop cardiac hypertrophy due to secondary hypertension. The patient can develop osteoporosis. Okay, and if the patient has a pituitary lesion, there may be an enlarged sella thrasica, although it is written in the literature that most ACTH secreting pituitary adenomas are microadenomas. They are less than 10 millimeters in size. Okay, and of course, a lady would complain of amenorrhea. All right, whether primary or secondary. Any problems so far? العيان اللي انتوا شفتوه كان فيه ايه من الكلام ده؟ ها؟ يا جماعة
هو يا دكتور انا العيان اللي انا اقصده ده ما شفتوش في الكورس الحالي زي من قبل كده يعني. كان عنده فيس وبافلو هامب وسنترال اوبيزيتي وكان دايابيتك.
ايوه.
بس يعني ده اللي انا فاكره.
بلاد بريشر كان ايه؟
لا مش قادرة افتكر الصراحة.
طب the rest of you يعني did you see a case of Cushing syndrome in the endocrinology clinical sessions or not? Or in the weekly scientific meeting? Huh? Can you please answer me?
يا دكتور
هو كان في كلينيكال سيشن، كان في مفروض كيس، بس انا ما حضرتش يعني السيشن ده، بس اعتقد ان شايفت فعلا كيس كوشن يعني
طب اللي حضروا يا جماعة كان ميل ولا فيميل بيشنت؟ وكان في ايه من الحاجات اللي انا قلتها؟ ها يا جماعة يعني I'm not talking to myself. When a question is يعني asked, I need an answer, please. If not, let's call it a day and we will all go to sleep or do whatever. But it's not ethical يعني that I ask you and you don't answer me. A simple I don't know will do.
هو أنا للأسف ما حضرتش السيشن
برضو مين حضر طيب؟ مين حضر؟
ايوه دكتور، شفنا تو كيسز دكتور سمير عرضهم علينا، كانوا فيميلز.
أيوة.
منهم واحده كانت persistent after surgery يعني، وواحده كانت يعني كان لسه باين عليها السيمبتومز، كان معاها هيرسيتيزم، كان معاها proximal muscle weakness. she was diabetic and hypertensive before surgery، بس يعني التو elements دول improved شويه بعد السيرجري.
اوكي.
دي كانت البيشنت اللي احنا شفناها يعني.
حلو قوي. what type of Cushing did she have? Adrenal ولا pituitary?
Pituitary origin.
All right, great. Thank you, Dr. Omne. Okay. طيب, let's go back to the slides. Where are the slides? Can you still see the slides? طيب. هنا طبعا أنا on this diagram I didn't include the hirsutism, but it will come later in the symptoms. Okay, so as you all know, clinical manifestations include symptoms, يعني the complaints of the patient. So on this table you can see the prevalence of the symptoms. The majority of patients complain of weight gain. Okay, I mentioned that Cushing syndrome occurs mainly in ladies, more common يعني in ladies than in gentlemen. So they will complain of menstrual irregularities up to amenorrhea. All right. Hirsutism, like Dr. Omnea mentioned, hirsutism. And by definition, what is hirsutism? Again, can somebody tell me? I explained to you this term before. What is hirsutism?
It's terminal hair in androgen-dependent areas.
Very good. Thank you. And 2/3 of the patients with Cushing syndrome will complain of psychiatric dysfunction, mostly depression. Okay. They complain of backache. Why do you think they have backache? Who can tell me?
Due to osteoporosis?
Yes, but mind you, osteoporosis itself is painless. When does osteoporosis become painful? When compression fractures occur. All right. And actually, I have seen a patient with Cushing's disease. She came presenting with weakness of the lower limbs, but not only weakness, but also numbness and paresthesia. And she had back pain, so we started searching because, you know, weakness can be due to Cushing syndrome or disease. Yeah. But we did a plain X-ray on the lumbar spine, and we found 2 compressed lumbar vertebrae, and these compressed the spinal cord. This is what caused the lower limb weakness and the paresthesia. You see, so very important not to neglect those symptoms. Again, muscle weakness. This is found in 29% of patients, but it has a high discriminant index. يعني discriminant index it's highly diagnostic for Cushing's syndrome. Okay, fractures, again, pathological fractures can occur in 19% of cases, and loss of scalp hair is seen in 13%. Okay, now what about the signs? These are the things that you as physicians detect when examining the patient. Obesity, 97%. كأن كل العيانين عندهم obesity. But mind you, what is commonly known about Cushing syndrome is that it causes truncal obesity. كرش بقى المتين. The breasts and the abdomen are large while the limbs are thin. Mind you, 55% of patients complain of generalized obesity. Here comes the dilemma, whether this is a case of simple obesity or a case of Cushing syndrome. We have to take a very good here in order not to confuse both conditions together. Plethora. What is plethora? Who can tell me? Plethora. What is plethora?
Flushing?
نعم.
Flushing of the skin?
مش flushing. هي هتقولي excessive redness, because flushing معناها active vasodilatation. This is not active vasodilatation. Why does plethora occur in Cushing syndrome? Who can tell me?
Polycythemia?
Yes, very good. Who was it, Dr. Omnia?
لا دكتور مريم.
دكتور مريم. Very good يا دكتور مريم. plethora يبقى من polycythemia. ماشي. طيب moon faces وش البيشنت بتبقى عامل زي البدر كده ليلة 14 شهر الهجري. moon faces، وعرفنا كلمة faces دي facial features of. okay. hypertension 3/4 العيانين. bruising. ايه bruising? Who can tell me what are bruises? What are bruises?
Hematomas?
Yes. They have also a high discriminant index, you see, 10.3. you have to suspect أكتر من red purple striae. شايفين؟ red purple striae, they occur in half of the patients, but the discriminant index is relatively low, 2.5 only. muscle weakness. شايفين لما كان symptom can only 29% complaining of it, but when you as a physician examine the muscle power of the flexors, extensors, abductors and adductors of the shoulder and pelvic girdle muscles, you will find muscle weakness in nearly half of the patients. Always remember to look for it. Ankle edema in half of the patients again. Pigmentation in 4%. Do you expect to find where do you find to expect pigmentation? In which type of Cushing? In Cushing's disease or in Cushing's syndrome? Or in ectopic Cushing disease? Why?
Due to high ACTH.
high ACTH. طيب why برضه؟ هل ال ACTH بيعمل hyperpigmentation؟
I think yes هو اللي responsible عن ال pigmentation.
يعمل stimulation للميلانوسايت، مش فاكرة اسم الهرمون بالظبط، بس فيه هرمون هو المسؤول عن البيجمنتيشن.
melanocyte stimulating hormone. هو it's said that melanocyte stimulating hormone doesn't exist in humans. إنما في a parent molecule for both ACTH and MSH اسمه pro-opiomelanocortin. شايفين؟ ميلانو من melanocytes، كورتين من corticosteroids. whenever ACTH rises, of course, the parent molecule كمان برضو is high. This is what causes the pigmentation يعني. Okay. طيب. Let me go back to the slides. I cannot see them. Yes. Okay, so pigmentation is found in in Cushing's disease. You can also find it in ectopic Cushing, of course, because in ectopic Cushing the ACTH level is very high. Okay. Type is like Dr. Omnea mentioned, diabetes. Here we don't call it just diabetes mellitus, no, or type 2 diabetes. No, it is called secondary diabetes because it is secondary to excess corticosteroids. It is found in half of the patients, but mind you, the majority of those, yani 37% have impaired glucose tolerance. Only 13% have overt diabetes. And the other half, they have osteoporosis, like we mentioned, okay? And only 15% have renal calculi. Why do you find renal calculi in Cushing syndrome? Who can tell me? Who can tell me?
Hyperuricemia?
Hyperuricemia, no. Hyper-EBA. مش اليوريك أسيد اللي عالي، إيه اللي عالي؟ في اليورين. يعني excreted in urine in excess. إيه بقى؟ كالسيوم يا جماعة، كالسيوم. Excess glucocorticoids can cause hypercalciuria, يعني excess excretion of calcium in urine. Okay? ده من الفسيولوجي على فكرة. ها؟ ماشي؟ always remember. But it's not common. But suppose you have a Cushing syndrome patient who's complaining of renal colics. يبقى you can associate, right? Okay? Type. Now, let me show you some pictures of patients. يعني here you can see on this picture a baby. This baby يعني عامل ازاي ده؟ شايفين متنفخ خالص كده. obese, جسمه مجزل من كتر الobesity. وشه عامل ازاي? How does the face look like? Huh? How does the face look like? مين يقول لي؟
Moon face.
Exactly. Moon face with facial plethora. Exactly. Very good. This is a young gentleman. This is the picture of the gentleman when he had Cushing syndrome and here after treatment. Here you can see the face is also, you see, rounded with facial plethora. But here the face became a little bit of oval and the plethora decreased. And here again, you see the abdominal stria rubra. By the way, the stria rubra, if you look closely, they are also seen on the antecubital fossa and on the anterior axillary fold. You see, they decreased here after treatment. Okay, so this to show you moon face. Again, this is a young gentleman and this is a young lady. They are not brother and sister. They are not related, but they look alike. What is similar in both of them? Who can tell me? What is similar?
الاتنين معاهم moon face وfacial plethora.
Yes. What else? What
buffalo
else?
hump ومش باين.
No, أنا كنت عايزة حد يقول لي buffalo hump. The buffalo hump is seen like this on this picture. In order to detect if a patient has buffalo hump or not, you have to look at the patient from the side in profile, like here. But here you see the buffalo hump, القتب ده بتاع البقر الوحشي, it's very prominent, so you can see it by looking at the patient from the back. Okay, this is a buffalo hump, but not this. You meant this, right? Dr. who? Dr. Mariam was talking?
Oh,
you meant this. You were talking about this. This is not a buffalo hump. What is this? These are enlarged supraclavicular fat pads. Why? Because there is a supraclavicular fossa. Fossa is a depression. But if you look here closely, where is the fossa? It is filled out by excess fat. And here again the same. You see, there is no supraclavicular fossa, but there is enlarged supraclavicular fat pads. And like you mentioned, moon face and facial plethora. What is this black line on this lady's chin. What would you call this? What is this? Can you see it? Can you see my cursor?
Hirsutism.
Exactly. This is a terminal hair on the chin. This is one of the androgen-dependent areas, like I mentioned previously. Is it clear? So again, this is the buffalo hump, Dr. Mariam. See? Because mild cases can be only appreciated while looking at the patient inside view. Okay? This is the buffalo hump type. If you look at this lady's, she is a patient, a female patient. Why am I saying that? She's wearing a nice nightgown, pink in color with nice lace, dentelle chic كده, huh? But if I cover the body and just by looking at her face, would you say she's a female or a male? What do you think? Huh?
Maybe a male due to hirsutism.
Exactly. She has temporal recession of the scalp hair, and she has extensive hirsutism on the beard and the mustache area. Okay, she has also moon face, but here instead of the plethora, she has pallor. So maybe the cause of Cushing syndrome in this lady is a malignant tumor. Okay, so this is again to show you the moon face and the hirsutism. This is a male patient. Okay. Who can tell me what, of course, the genitalia are covered, yani for the dignity of the patient, but who can tell me بقى the significant signs in this picture? What do you think? Who can tell me?
في central obesity.
ايوه شايفين ناخدها بس one by one. شايفين البوت belly ده الكرش المتين وبريست هنا كأنها كبيرة والثوركس يقارنوا كده the limbs compared to this abdomen, they appear thin. This is truncal obesity, truncal or central obesity. طب let me ask you another question يا دكتور. Does he have a true or false gynecomastia? أنا قلت لكم he is a male subject, a male patient. Whenever there is breast enlargement in a male, we call it gynecomastia. صح؟ طب in other words, how can you determine whether this is true gynecomastia or false gynecomastia أو pseudo gynecomastia? PSEUDO. نعم؟ مش سامعة. ولا سامعة حاجة. صوت بيقطع. How would you differentiate? Sorry? I can't hear you. Who is talking? Who is Dr. Ala Hamid? I can't hear you. The voice is interrupted. Who else can tell me? How can we differentiate? Do you understand the question? How can we differentiate between true and false gynecomastia? Yes, Dr. Omneya, you wanted to answer? Dr. Omneya. Dr.
maybe by palpation. بنعمل palpation.
Exactly. How do you palpate? How do you palpate? Side to side? Or
circular movement كده around the nipple.
craniopodal ولا بتعملي ايه؟ لا circular movement يعني زي كأنك بتpalpate the breasts of a female patient؟ لا.
No, at the nipple. If I felt the glandular tissue.
طيب يبقى you compress. Let me show you the picture again. يبقى okay. Can you see my cursor? Imagine this is my index finger, okay? So I'm going to put my index finger on the nipple of the patient and then I compress, okay? If I can feel the rib underneath my index finger through the fat of the breast tissue, this is false or pseudo gynecomastia. But if I feel a disc of tissue intervening between my index finger and the underlying ribs, this is true breast tissue. So this is true gynecomastia. Is it clear? Am I clear?
Yes.
Okay, great. Type, what else? What other signs can you see in the picture? What other signs?
Muscle wasting.
Muscle wasting. Type. Here you can see, this is, I keep saying, this is a male patient. usually males are muscular, right? يعني مش لازم يبقى محمد صلاح يعني. But look at the quadriceps femoris and the gastrocnemius. They are very thin, as if they are atrophic يعني. Huh? They're wasted كمان. طب look at the deltoid. Where is the roundness of the shoulder? As if the shoulder is flat, يعني كأنه مربع كده شايفين؟ So there is wasting even, not just يعني muscle weakness, لا كمان في wasting, visible wasting of the deltoid and the quadriceps femoris muscles. طيب what else? What other signs can you see?
Stria.
Yes, stria rubra on the abdomen. And here they extend down to the thighs as well. Very good. طيب. What is this patch here? Bluish patch.
Hyperpigmentation أو bruise.
No. أيوة دي bruise. طبعا we don't know if it's related to blood sampling or spontaneous. We don't know. إذا كانت spontaneous, it has a higher even discriminant index. And here is another bruise. And here, you see, there is a bruise here and there. And the skin appears as if it's thin and it's not healthy. The skin doesn't appear healthy, right? And as if there is a wound here and with poor wound healing. So what about the ankles? Is there something visible in the ankles? What do you think? What do you think?
Edema.
Exactly.
Edema.
Ankle edema. It's more obvious on the right side. Very good. So anything else you want to add? طيب, let me show you. This is to show you an easily bruised and wrinkled skin with abdominal stria rubra, proximal muscle wasting and myopathy, like we mentioned, ankle edema. Okay. Type. This is a female patient showing abdominal stria rubra, truncal obesity. You see, but this is what. Can you see the bluish black? This is a bruise. Top, and this is what. This is another patient having this lesion. What is this lesion? What is this?
Acne?
No, it is another bruise. طب how come not يعني both bruises are of different colors? اشمعنى دي لونها كوبيا كده ودي لونها pink؟ اشمعنى؟ مين يقول لي؟
الage بتاعهم.
Exactly. Whenever the bruise occurs, يعني واحد if you strike your hand or whatever, your arm or forearm against something, and it turns black or dark blue in color. This is a fresh hematoma or fresh blue bruise, and then the color changes because of the changes of the released hemoglobin in the skin, in the subcutaneous tissue. It turns greenish blue in color and then brownish in color, and then when it starts to fade away, it becomes like this color. You see? So this is, and if the bruise, if you found this bruise and you ask the lady, did you strike your arm against something? And she looks like that. No, I didn't strike my arm. This is the first time I noticed this bluish discoloration. So this is a bruise without obvious injury. This is the one that has the high discriminant index of 10.3. All right. Now coming to these pictures. This is a picture of a lady. Okay. And this is a picture of a gentleman. Both of them have what? Who can tell me?
Truncal obesity and stria rubra.
And yes, this is to show you the stria rubra. The typical stria rubra seen over the abdomen in Cushing syndrome patients are purple red in color, like here and there, and they are wide, more than 1.5 to 2 centimeters in width, and the skin overlying is atrophic and very thin. Okay, type. The typical site for stria rubra is the anterior abdominal wall, like here, but here they are extensive. You can see them even in the lumbar region and over the buttocks. And as I mentioned earlier, the gentleman I have shown you very in the very first slide had also stria rubra over the antecubital fossa and the anterior axillary fold. And in ladies, it may be also seen on the breasts or on the buttocks or on the thighs. Okay. Type this lady. What is this? What is this dark line in the middle? She is a female. Why? Because you see the pubic hair has has the base located upwards, but this is hair rising to the umbilicus, right? Is that normal in a female?
No.
Type, is this hirsutism? Can you consider this hirsutism part of يعني hirsutism?
Yes.
طيب, because it is an androgen dependent area, مش كده؟ طيب, does this gentleman have gynecomastia?
I don't think so. لا.
ما هي البريست شكلها كبير شوية مش كده؟ بس you have to distinguish بقى whether they are يعني true, whether this is true gynecomastia or false. ازاي? We are going to compress on the nipple. If you feel a breast tissue underneath your index finger, this is true breast tissue, so it's true gynecomastia. If you feel the rib, خلاص, this is false or pseudo gynecomastia. Is it clear? So these were abdominal stria rubra. نعم. قولي لي.
هي البالبيشن بتاعت الموبايل كان فاصل وقتها، بتبقى سايد تو سايد ولا سيفاريك؟
لا بصي حضرتك، شايفه الكيرسر بتاعي؟ شايفاه الاحمر ده؟ بتضغطي لتحت، يعني لجوه. العيان كانه نايم مثلا على السرير، بتضغطي من فوق لتحت. يعني بصي هوريكي الصوره، انت شايفه صوتي لسه؟ Can you see my video? طب suppose this is the breast, this is the nipple, this is how you compress. You see? So if you feel a breast, if you feel a disc between your index and the underlying rib, this is breast tissue, true breast tissue. But if you feel the underlying rib under your index finger through the fat, this is false gynecomastia. Is it clear? Okay. طيب. Am I going too fast? Any problems? Any questions? طيب. Can you still see my slides? Let me continue. طيب. You see, this is a gentleman and this is a child, a female child. This is not the daughter of this gentleman and he is not her brother. They are not related, بس هما شبه بعض. What are the similarities? Who can tell me?
Moon face, plethoric face.
Exactly, moon face with facial plethora, more evident in this girl. Type, what else?
Truncal obesity.
Exactly, both of them يعني كأن كورة كده هنا وكورة هنا، مش كده؟ While the limbs are relatively thin. Okay, what else? يعني شكلها عاملة زي orange on a stick. عارفين لما when you take the stick of a barbecue كده، وتحطي عليه ليمونة القضاليا أو برتقانية صغيرة. This is how it looks like. You can read it in some textbooks. They call it orange or lemon on a stick appearance. Okay, طيب. What else?
Proximal muscle wasting.
Yes, more evident in the gentleman, of course, because the male subjects are supposed to be muscular يعني مش كده؟ طيب. Very good. What else?
Ankle edema.
Yes, باينة أكتر في البنوتة يعني مش كده؟ بس هو عنده كمان. طيب. What is this? You see, he's applying ointment on something. What is this structure?
bruise تقريبا ولا
bruise. دي شكلها bruise. bruise. لا مش ulcer، دي bruise. وهنا كمان في، شايفين؟ هنا كمان في الانتيكيوبيتال region. الله أعلم is it related to يعني blood sampling ولا spontaneous. And برضه the dorsum of both hands appear يعني dark purple in color. most probably عليهم برضه bruising يعني. Okay. طيب what else? هي طبعا البنوتة دي she's not yet, she didn't reach puberty yet, but you can see the breasts are برضو enlarged. But here يعني she may or may not have gynecomastia. You have to palpate برضو. But what about this gentleman? هي طبعا البنوتة دي مش هنقول بقى gynecomastia لأنها بنوتة يعني إنما this male patient هل ده عنده gynecomastia ولا لا بالشبه كده؟
Yeah.
Yes, type. Is it true or false? You cannot tell just by looking at the picture. You have to palpate over the nipple. وفهمنا يا دكتورة مين كانت بتسأل؟ دكتورة ماجي. Now we know how we compress, right? Anything else you want to add? طب in this girl ليه محطوط جنبها مزورة? Why do you think في measuring tape?
short stature أكيد أو
Exactly. This indicates that excess corticosteroids in children can be a cause for short stature. خلاص يبقى كان عندنا cause قبل كده قلناه زمان في أول revision. كان مين فاكر يقول لي أو المرة اللي فاتت؟ who remembers؟ نعم؟
Hypothyroidism.
Exactly, hypothyroidism. Very good. So here is to show you the lemon on stick appearance that I just mentioned, meaning that there is central obesity and remember short stature in children. Okay. Now coming to the important and very interesting part, اللي هي imaging in Cushing syndrome. Imaging. أنا قلت لكم قبل كده that in the coming exam you will have several stations. One of them will be an imaging study, either يعني a CT or MRI تمسكيها كده في ايدك or on the computer. فيعني don't get confused. Computer زي ما بوري لكم دلوقتي يعني. Okay? Don't get confused. طيب. If you have احنا قلنا Cushing syndrome, if it is due to ACTH secreting pituitary adenoma, the imaging of choice is what? MRI of the pituitary gland. فاكرين؟ طب ايه classic features of a pituitary microadenoma؟ اولا this is مين يقول لي بقى، مين يكومنت؟ مش فاكرين؟ You remember the comment on the MRI of the sella turcica that we have revised in the very first session? Who will tell me what is this imaging؟ يلا يا جماعه. الايمج دي يا جماعه ايه؟ ما مكتوبه اهو MRI بس الفيو بتاعتها احنا قلنا you have to comment on the imaging technique. This is an MRI on the pituitary or on the sella turcica. طيب الكت هل هو axial ولا coronal ولا sagittal؟ coronal مقطوع كده كويس along the coronal suture. طب هل عاطي contrast ولا لا؟ الاول T1 weighted ولا لا ولا T2 weighted؟ How do I T1 لأن CSF is black. Oh, very good. طيب عاطي contrast ولا لأ؟
I think لا من غير contrast.
لا عاطي contrast. ليه بقى؟ هقول لك ليه. أولا خلينا ريفايز الأناتومي تاني. هنا ده air is black يبقى air in the oral cavity, air in the sphenoidal sinus. This is the sella turcica. فاكرين احنا normal anatomy? Remember when I told you that the upper border of the pituitary gland should be either flat or concave. But here if you look closely it is convex, right? This is the pituitary stalk and this is the optic chiasma. Here is the cavernous sinus with the carotid artery and the other cavernous sinus with the carotid artery. Ulnar carotid artery appears black because it contains flowing blood. Here the pituitary stalk, if you look closely, it should be central, but here it is deviated to this side. Okay? خلاص؟ طب if you look closely برضه هتلاقي the pituitary appears somewhat white in color, while the arrow points at the filling defect or a hypoechogenic area inside the pituitary. This is a pituitary microadenoma. خلاص؟ يبقى there is a hypodense lesion after contrast. It is associated with deviation of the pituitary stalk and a convex upper surface of the pituitary gland. These are the classic features of a pituitary microadenoma. Is it clear?
دكتور معلش احنا عرفنا منين ان هو بكونتراست؟
هقول لك عشان بصي حضرتك شايفه هنا pituitary اهي، قارنيها ببقيه البرين، شايفه هي كانها بيضه زياده عن البرين، صح؟
Yes.
وكمان if you look inside it you will find a filling defect. دي مش بنقول filling defect، بنقول hypodense lesion. يعني البيتيوتري أخذت الكونتراست بس this lesion didn't take it. فهمتي؟
Okay.
Okay, fine. Any problems? Any further questions? Just tell me and I will repeat. Any queries? Huh? Okay, now coming to the CT of a normal adrenal gland. خلاص؟ normal خلي بالنا. I'm showing you the normal first زي ما عملنا المرة اللي فاتت في أول مرة خالص. I showed you the MRI of a normal pituitary عشان نقدر نشوف الabnormal. خلاص؟ طيب let's discuss. This is what cut is that؟ احنا قلنا كل ده CT ها؟ CT. طيب cut ده عامل ازاي؟ Is it an axial cut؟ axial ولا sagittal ولا coronal؟ coronal. axial very good. طيب والكات ده عامل ازاي؟ ده ايه؟
sagittal.
ايوه لا مش sagittal بقى، كورونال. sagittal يعني كده شايفة صورتي؟ sagittal يعني along the sagittal suture. coronal يعني
Yes.
along the coronal suture. ماشي؟ axial يعني كده. خلاص؟ طيب let's discuss. هنا posterior. This is posterior, this is anterior, this is right, this is left. Bone on CT appears white. خلاص يبقى this is a vertebra. These are the ribs. ماشي؟ Okay? طيب we have to look at this is right and this is left. يبقى this is which structure? احنا هنا في الابdomen at the upper abdomen. Upper يعني at the level of the adrenal glands. خلاص? This is what structure on the right side?
Liver.
The liver. This is which structure on the left side?
Spleen.
Exactly. طيب now what is this structure in front of the vertebra? This one.
Aorta.
Exactly. Abdominal aorta. طيب هل الأكزيال CT ده with contrast or without?
Without.
Without. حلو قوي. ليه؟ لأن الأورطة مش منورة. It doesn't appear white. It appears gray زي بقية الستراكشرز صح؟ حلو قوي. طيب what is this structure? Can you see the cursor on the right? And this structure. لا, which part of the diaphragm يا دكتور? You have to be specific. أهي. شايفين? This structure.
Right.
And نعم.
Right و left.
إيه بقى؟ crura. These are the crura of the diaphragm. Right, this is the right crus of the diaphragm, and this is the left crus of the diaphragm. ماشي؟ طب أهميتهم إيه يعني? Why is it important to look at the crura of the diaphragm? Can somebody tell me?
الثيكنس بتاع الادرينال جلاند اعتقد ما ينفعش يكون اكبر.
Exactly. Very good. Very good. Type. Let me show you. This, you see the red arrow here is pointing at the right adrenal gland. It appears like an inverted Y. صح؟ طب look at the medial limb اللي هو هنا. Look at the thickness of the medial limb. Is it thicker ولا thinner than the right crus of the diaphragm?
الادرينال جلاند thinner.
Thinner بالظبط. This is a normal adrenal gland. And look at the other red arrow on the left side. This is the left adrenal gland. It appears like the Mercedes sign. عارفين علامة المرسيدس؟ خلاص؟ طب look at the medial limb of the left adrenal gland and compare it to the relevant crus of the diaphragm. Is it thinner or equal to or thicker than the left crus? What do you think?
It's equal to the left crust.
لا يعني if you measure بقى بالمليمترز بالظبط هتلاقيها thinner. Somewhat thinner. مش زي دي يعني بس somewhat thinner. Okay? And these are the loops of intestine. طبعا هنا ممكن يكون واخد oral contrast because the loops of intestine are somewhat white in color. وهنا في air floating. دايما air أخف من الفلويد. air is floating. Air appears black. ماشي؟ خلاص؟ طب نيجي هنا الصورة اللي على اليمين دي. This picture on the right side. احنا قلنا this is what a coronal cut. Vertebrae appear white اهو. خلاص؟ طيب. This is what?
The liver.
لا شايفة أنا ده إيه ده؟
The right crust of the.
أيوة this is the هنا right crust أهو و right cupula ماشي of the liver of the I mean the diaphragm and underneath is the liver. So this is the right kidney. هي مقطوعة coronal فهي longitudinal يعني فدي cortex أهي ومضلة ماشي. طيب ادي الناحية التانية. This is the left crust of the diaphragm and this is the left cupula. تحتها في ايه؟ stomach والspleen اهي ماشي. And this is the left kidney. اوكي مقطوعة برضو longitudinal فادي cortex وادي المضلة. تمام؟ طب let's look at the structures above the right and the left kidney. شايفين هنا؟ Inverted Y shape برضو. Compare the medial limb of the Y with the relevant crust. هنا باينة قوي ان هي ارفع نصه مثلا ولا حاجة صح؟ طب compare the medial limb هنا شكلها زي الايه؟ Mercedes sign. Compare the medial limb to the left crust. You see? It's برضو half the thickness. Is it clear?
Yes.
Okay. Hannah, did they use any contrast? ايه رأيكم؟
لا no contrast.
لا برضه
no contrast. طيب كمان حاجة برضو I wanted to point out is شايفين what is the black يعني the black structure around the adrenal and the kidneys مش كده في black tissue كده أو black يعني color إيه black color دي؟ إيه دي؟ fat exactly very good this is perinephric fat هنا برضو نفس الحكاية perinephric fat okay is it clear؟ طيب this was the CT of a normal adrenal خلاص now let's look at this CT. Yeah, meaning who would like to comment? As if you are in the exam and commenting. This is what? Who would like to comment?
contrast.
أجزي
يعني حد واحد يقول يا جماعة مش يعني in the exam you're not going to answer all at the same time. Just one who would like to answer. Who started first? Dr. Maggie, I think. Dr. Maggie, you started. Time. Can you still see the picture? Please comment. Yeah.
axial لا CT axial with contrast لأن الأورطة منورة.
ايوه very good هنا واضح مش بس الاورطه كمان شايفه البورتال تراكتس شايفه جوه الليفر كله منور بس البورتال تراكتس ابتدت تبقى بيضه قوي واضح طب what else
enlarged adrenal هي أكبر من الديافراجماتيك كورة.
اللي هي دي مش كده اهي ايوه
اتنين.
الاثنين يعني شايفه في there is a white arrow pointing at the right adrenal اللي هي اهي and another white arrow pointing at the left adrenal اللي هي اهي صح both of them are like 5 times or more the thickness of the relevant crust of the diaphragm صح and this is what this structure here this is what
kidney.
This is the upper pole of the right kidney. You have to be specific, doctor. And this is what?
Upper pole
of the left kidney both. Can you see the perinephric fat? Is it normal ولا increased? هنا increased. شايفة increased. لأن ما هو في الكوشنج syndrome الترانكال obesity دي جت منين؟ مش بس deposition of fat in the subcutaneous fat of the abdomen. لا كمان omental in the omentum. Okay? Is it clear?
I mean.
So this is what we have. Both adrenal glands are enlarged, right? What could be the cause? Who can tell me? What could be the cause of bilateral adrenal enlargement? What causes bilateral adrenal enlargement? I can't hear anything. The voice is interrupted.
Cushing's disease.
Sorry?
Cushing's disease.
طيب يعني it is bilateral adrenal hyperplasia. It's Cushing syndrome due to bilateral adrenal hyperplasia. Most probably, of course, it can be due to either an ectopic source of ACTH or an endogenous increase of ACTH secretion from a pituitary microadenoma. Very good. طيب, now coming to this CT, who can tell me what is seen on this slide?
CT axial without contrast.
لا, you have to mention CT of which part of the body. يعني is it brain, pituitary, thorax, abdomen? Yeah, you have to mention. يبقى CT abdomen at the level of the adrenal glands. Axial cut. Axial cut. Showing ايه بقى? I will point at some structures and you tell me what is this. What structure is this? Can you see the cursor?
upper pole بتاع left kidney.
طيب هي هنا بقى الحقيقة مش upper pole لأن أنت you can see actually a part of the medulla فكأنها مقطوعة يعني مش كده؟ this is the left kidney فعلا يعني ماشي the left kidney okay طيب this is what structure this one
aorta.
the abdominal aorta you have to be specific عشان في descending aorta في okay طيب and this is what structure what is this vertebra. Okay, what are these white structures?
Ribs.
The ribs, very good. Type. What is this? See, this mottled structure. What is this?
Colon.
Intestine. Yeah, intestine. Type. في air وفي oral contrast. عشان كده شكله عامل كده. What is this structure?
Liver.
Liver. حلو قوي. طيب. نيجي بقى. What is this structure?
right adrenal
لا. Can you see my cursor? بصي. This structure. What is this?
right cupule diaphragm.
Yes, right cross of the diaphragm. And this is what?
Cross of the diaphragm.
Left cross of the diaphragm. Type. This is which structure? Okay.
Right kidney.
أيوة هنا بقى you're justified to say the upper pool. Why? Because you cannot see the medulla, cortex and medulla. It's just the kidney, the upper part of the kidney, upper pool of the kidney. طيب, let's look at the right adrenal. أهي. شايفة right adrenal؟ طيب, الميديال limb بتاعها is it a thinner ولا thicker ولا as equal as the right cross of the diaphragm؟
thicker.
لا. أرفع ولا أضخم؟ بصي عليه كويس. medial أهو ده.
أرفع يا دكتور.
أرفع. حلو أوي. طيب. What does the arrow, the white arrow point at? What is this? What is this?
Adrenal enlargement.
Which adrenal, left or right?
Left adrenal.
أيوة. يبقى there is a left adrenal mass. يبقى this is a case of Cushing syndrome due to left adrenal adenoma. Adenoma is, of course, a benign adrenal tumor. ماشي? Is it clear? طيب, let's look at this very interesting case. This is very rare طبعا, بس يعني I have seen only one case من سنة 1991 لحد النهاردة. What is the picture showing? Who can tell me?
CT abdomen.
Yes.
At the level of adrenals.
Yes.
Axial cut.
Yes.
Without contrast.
Without intravenous بقى عشان هو واخد oral contrast. هنا في oral contrast اهو. صح؟ طيب, without intravenous contrast showing ايه بقى؟
bilateral adrenal enlargement. مش عارفة بقى صح ولا؟
ايوه. طيب, يعني هنا دي abdominal aorta اهي. ماشي؟ right cross of the diaphragm, left cross of the diaphragm. شايفين the black arrows point at all this structure and all this structure. طيب, let's describe بقى what we see. طبعا لو if you compare the thickness of the left the right adrenal gland with the relevant cross هتلاقيها مثلا 5 times as thick as. صح؟ If you compare the thickness of the left adrenal gland to the left cross of the diaphragm هتلاقيها مثلا 7 times as thick as. صح؟ طيب, بس is the adrenal structure preserved? يعني does it look like an inverted V or Y shape ولا شكلها ايه؟
No.
شكلها ايه بقى؟
nodular كده.
ايوه, nodular. very good. طب هل دول micro nodules يعني small nodules زي سبحة كده ولا macro nodules؟ ايه رأيك؟
macro
macro.
nodule.
Here there is a big nodule. Here another big nodule. Here another big nodule. Here another one. And here another one. طب let's look at the left side. Another big nodule. Here, there, here, here, and here. يبقى this is what? This is what? من ضمن الكوزز بتاعت الكوشنج سيندروم ايه بقى؟ حاجة اسمها ايه؟ macro nodular adrenal hyperplasia. يبقى this is a case of Cushing syndrome due to massive macro nodular adrenal hyperplasia. And again, the perinephric fat appears to be enlarged. شايفين الحتة السوداء اللي هنا واللي هنا؟ It appears very large أو larger than normal. طب مين شاطر يقول لي what this structure is? What is this structure? Who can tell me?
Pancreas.
Pancreas, very good, excellent. And this is, of course, these are loops of intestine filled with oral contrast and air, all right? And this is the liver, very good. Now let's look at this interesting CT. Who can tell me? What is this? If you don't know the pathology, just describe what you are seeing. When you describe, you will get marks. And not only that, but also maybe you will be able to detect the lesion eventually. So, what is this? What is seen on this slide? Come on, easy. Describe. I will point at structures. This is what يعني in general this is مكتوب اهو CT scan of the abdomen at the level of the adrenal glands. Axial cut with contrast or without IV يعني I mean without intravenous contrast but with oral contrast صح؟ طيب showing دي ايه بقى؟ What is this structure?
vertebra.
Vertebra. What are these white structures?
Ribs.
Ribs. طيب what is this structure?
Abdominal aorta.
Exactly. طب what is this structure?
Right cross of the diaphragm.
Exactly. What is this structure?
Left cross of the diaphragm.
Okay. What is this structure?
Left kidney.
هنا pancreas. kidney لسه ما ظهرتش. ده مش البانكرياس I mean السبلين. أنا قلت pancreas. لا this is the spleen. Okay. ده البانكرياس أهو. ده البانكرياس. And these are the loops, bowel loops filled with air and oral contrast. This is which structure?
Liver.
Twice. Top. The black arrow is pointing at what? What is this? What is adjacent to the liver يا جماعة؟ ايه دي؟
gallbladder.
نعم؟ لا. Adjacent between the liver and the crus of the diaphragm, the right crus of the diaphragm. What is this structure?
Adrenal.
Which adrenal? You have to be specific.
Right adrenal.
Exactly. Right adrenal gland. Top. Does it look normal?
No.
What is abnormal? What is the abnormality? أولاً, the medial limb appears thicker than the right crus of the diaphragm. صح؟ طب if you look closely at the medial limb, is it smooth كده ولا is it برضه nodular? What do you think?
Irregular.
طيب هل ده macro nodules زي اللي فاتت ولا دي micro nodules?
Micro nodules.
Micro nodules, exactly. So this is a very rare condition. I have seen also one case in my life. Cushing syndrome due to primary pigmented nodular adrenal disease. Pigmented later, and when they remove the adrenal, it appears pigmented. So this is why it is called pigmented. Okay? Right, let's look at this interesting case. I have seen 2 cases like that. This is what? The anatomy here appears different, right? طب إيه بقى? Who can describe it? What imaging is that?
هو برضو CT abdomen.
أيوة.
axial front.
أيوة. With contrast or without?
With contrast.
With contrast. لأن هنا الabdominal aorta والinferior vena cava شايفين they appear brighter يعني almost as bright as the bone يعني ماشي وعاطي كمان oral contrast لأن ده bowel loops filled with gastrography. طب where is the liver بقى? Where are the crura of the diaphragm? الاناتومي اتغيرت صح؟ Where are the ribs? مش كده vertebra اهي. Where are the ribs? Instead of the ribs we have what? What are these structures? ايه دول؟ اللي لونهم gray دول ايه دول؟ What are those structures?
هي الريبس بس T2.
No. T2 ده في الام ار اي يا دكتورة. We are seeing a CT هنا. But don't confuse things. T2 weighted images are seen in the context of magnetic resonance imaging, a totally different imaging modalities. Here we are speaking about CT scan يا دكتورة. Okay? ايه بقى دول؟ ايه structures دول يا جماعة؟ ليهم نفس التيشو density of this structure and of this structure. These structures. ايه دول بقى؟ What are these? Remember your anatomy يا جماعة؟
muscles.
Exactly. The muscles of the anterior abdominal wall. Layers of muscles. وادي هنا في النص اللينيا قلبة اللي هي بين التو ريكتاي. ماشي؟ طيب امال ايه اللي جوه دي؟ What is the structure between the kidney and the body of the vertebra? اللي هي دي ودي. What are these structures? ايه دول؟ الإيليوسوس يا جماعة، الإيليوسوس ماسل، ما هي مش دي ماسل برضه زي دي، نفس التيشو density، نفس الهاونسفيلد units. These are the iliopsoas muscles. طب أمال what are these muscles adjacent to the spine of the vertebra؟ دول إيه بقى؟
paravertebral.
Exactly، اللي هم الإريكتور سبايني يعني، مش كده؟ طيب أوكي، طب إيه الأناتومي دي بقى؟ فين الليفر؟ هنا you can see the left kidney cut across and the right kidney cut across، صح؟ يعني as if we are not at the level of the adrenals, we are lower down because you can see the abdominal aorta and the inferior vena cava، مش كده؟ طيب طب أمال إيه بقى كل دي؟ What is this? What is this? Describe this lesion. Don't tell me the pathology, describe it. We have a large globular lesion adjacent to the right kidney, right? The size is more than 5 centimeters. Here you can see the scale, كأنه حاطط مسطرة for comparison. The size of this lesion is more than 5 centimeters in size. And look at the, يعني, is it homogeneous or heterogeneous? يعني, does it look like the muscles كده نفسها even? ولا في حتت كده كأن في areas of breaking down? What do you think? نعم؟
في heterogeneity يعني
exactly. يبقى في a large heterogeneous lesion, rounded lesion, more than 5 centimeters in size, adjacent to the right kidney, with areas of breaking down. What could, and the patient presented with Cushing syndrome. What is the possible cause of this?
Adrenal infarction?
No, adrenal carcinoma. Whenever the tumor size or the adrenal يعني, size is more than 5 centimeters in size, you suspect adrenal carcinoma. Not only that, but if you do a CT, يعني, if you look at a higher cuts of this patient's CT, you will find liver metastasis. You see, this is a CT abdomen of the same patient, but at a higher level, يعني, at the area of the pleural recesses. You see, this is the liver, this is posterior, this is the vertebra, these are the ribs on the left side, the ribs on the right side, this is anterior, this is the liver, and this is the descending aorta, and this is the left pleural recess, or the lowermost part of the left lung. It appears black because it is full of air, and here is the right, the lowermost part of the right lung, but again, it's full of air, this is why it's black. This is the liver. Look at the liver closely, the portal tracts. But is the liver يعني density homogeneous? No, it is heterogeneous, with these areas with having the same tissue density as this area, right? So this is a case of adrenal carcinoma presenting with large liver metastasis. Actually, I have seen 2 cases in my whole life. Both of them were male patients. Both of them presented with full-blown picture of Cushing syndrome. One of them was 35 years old, quite young. يعني. He had a huge left adrenal carcinoma with metastasis to the spleen and to the liver. The other patient I have seen, of course, this patient was inoperable, so we tried to give him mitotane. Mitotane is a drug used to prevent excessive formation of corticosteroids by the adrenal cortex. It wasn't available in Egypt at that time. Unfortunately, the patient passed away before the drug arrived from abroad. The other patient I have seen was a very poor, يعني 17-year-old boy. He had a huge, large adrenal carcinoma metastasizing to the liver, like this. Okay, and unfortunately, Bordeaux, he passed away. It was inoperable. Yeah. All right. Type. Now coming to ectopic ACTH syndrome. Yeah. So far, any problems? Was I too fast? Any difficulties? Anything that is not clear? Tell me, and I'll repeat. Type. Let's continue. Have you heard of ectopic ACTH syndrome? Huh?
Yes.
Okay, it occurs usually with malignant tumors of the lung, small cell carcinoma of the lung, or of the pancreas, or of the ovaries, and so on. خلاص? طيب, look at this imaging technique. What is this imaging technique? This is what?
Plain X-ray chest.
Yes, plain X-ray chest, PA view. Let me revise the anatomy. This is the right clavicle, the left clavicle, and this is the trachea, air-filled. You see the black area here, and this is the cardiac shadow. All right, and this is the right cupula of the diaphragm, the left cupula of the diaphragm, and these are the ribs. You count them from behind. Okay, طيب. If you look closely, this arrow is pointing at a suspicious lesion behind the cardiac shadow. خلاص? So this is the resolution of the plain X-ray. They did a high definition CT scan of the thorax. Okay, also axial cut, transverse like that. This is the anatomy, posterior, anterior, right, left. But let me review the anatomy with you. This is the thoracic vertebra. Here are the ribs, all right? This is the right lung filled with air. This is why it appears black. This is the left lung filled with air, appears black. This structure is what? Huh? This is the descending aorta. Okay, we are in the chest here. This structure in front of it is what? Look closely. There is a central lumen and a thick wall. Esophagus, exactly, very good. And this is the upper part of starting the liver, yani the right cupula of the diaphragm starting the liver, okay? The arrow points at what lesion? And this is, by the way, the rest of the cardiac shadow. This is the lesion that was seen earlier. It was suspicious here, you see? This one. But here on high definition CT, you can see a bronchial carcinoid tumor behind the cardiac shadow. All right. So this is another CT scan of the thorax, but here this is a sagittal reconstruction. Sagittal. This is the anterior. This is posterior. So this is the sternum. This is why it appears so white, and these are the ribs from behind. This is why they appear white. And here are the two cupula of the diaphragm. They are superimposed because it is in lateral, يعني كأنها lateral view, sagittal. Okay, أو cut يعني cut, a sagittal cut. And this is what? This is the cardiac shadow. Why does it appear so white? Because they have administered intravenous contrast. Now the lungs have become mottled like that, black and white. The black areas represent the air in the alveoli, while the white areas represent intravenous contrast in the vasculature of the lungs. Now, what is the arrow pointing at? This is the bronchial carcinoid that appeared on plain X-ray behind the cardiac shadow. Can you see how clear it is now with the high definition CT? Is it clear?
Yes.
Okay. Now coming to the ectopic, the malignant ectopic ACTH, يعني a bronchial carcinoid can be benign, but in spite of that, برضو it can secrete excess ACTH. يعمل لنا ACTH ectopic ACTH secretion. Suppose بقى we have a small cell carcinoma of the lung. It's very small in size, and you cannot see it on CT لوحده. You cannot see it on you cannot see it. Like, how do you visualize it? By doing a scintigraphic study called radioactive labeled indium octreotide scintigraphy or octreoscan. Why is that? Because they discovered that some neuroendocrine tumors, if they don't only have secrete ACTH, but they also have receptors for octreotide. Okay, so this is how they can visualize them. They use a radioactive labeled octreotide scintigraphy.
دكتور الصوت بيقطع. الصوت بيقطع يا دكتورة، الجزء اللي فات ده ما سمعناهوش كويس.
الصوت بيقطع من أول فين يا دكتورة أمنية؟
من أول الإكتوريتايد سكان، يعني حضرتك كنت بتشرحيه.
طيب can you hear me now? Is my voice clear?
Yes, yes.
طيب let me discuss. يعني the indium labeled octreotide scintigraphy is used to detect ectopic ACTH secreting malignant tumors. Why? Because it was found that they have receptors for octreotide. Okay, so you can use actually a radioactive labeled octreotide to be taken up by these receptors. All right, so let me show you the imaging. These are as if the octreoscan here in axial, here in sagittal, and here in coronal view. Can you see my cursor? Let me put it as a laser pointer. This is the sagittal. I mean this is the axial. This is the sagittal, and this is the coronal view. Look closely at the left hilum of the lung. There is an area of uptake here. Here they became two parts, and here more obvious. So actually, the indium labeled octreotide scintigraphy or the octreoscan visualized a small cell carcinoma of the lung. And obviously, this is the source of ectopic ACTH. Is it clear now? See how the imaging can be very helpful? Is it clear?
Yes, yes, doctor.
Okay. Any problems so far with Cushing syndrome? Of course, you need to know the different tests the hormonal yani tests to detect how to screen for Cushing syndrome, how to do the low dose dexamethasone suppression test, which is one of the screening tests, how to do the high dose dexamethasone suppression test, and how to measure the plasma ACTH. You know all that, right? Huh?
Yes, doctor.
Okay, fine. Now let's shift. Are you tired? Are you tired?
No.
طيب. Let's shift. Damina بتقول no. Only one is talking. What about the rest of you? Huh? Are you tired? The rest of you? I'm left with only 5 students يعني out of 26.
No, doctor. No.
It is actually يعني very miserable يعني that out of 26 students only 6 are attending يعني. But since you are attending and you want to listen to what I have to tell you, خلاص, I'm here for you, as I mentioned. Now coming to Addison's disease. Now let me discuss the clinical features of primary adrenal insufficiency, the other name for Addison's disease. Okay. On this slide, you can see diagram. You can see all the manifestations of hypoadrenalism. Usually, a patient comes complaining of drowsiness, confusion, or even coma. The patient has excessive pigmentation all over the skin, the buccal mucosa inside. I'm going to show you. And even if she has if she has had, or he, if they have had previous surgery, the scars would be pigmented. The patient will complain of anorexia, nausea, vomiting, abdominal pain, maybe diarrhea. Okay. There is also very profound muscle weakness. Again, there may be associated vitiligo if it is autoimmune, or if the patient has removed the adrenal glands, you will be able to see scars of previous adrenalectomy. Or the patient may have a history of bronchial asthma, for example, treated with steroid therapy. Okay. And if the patient has Schmidt syndrome, you may find a goiter in addition to the hypoadrenalism. Of course, you will find hypotension with further postural drop. Okay. And in women, you can also detect loss of pubic hair. All right. These are all in all the clinical manifestations in hypoadrenalism. Okay. So let me subdivide them into symptoms. As I mentioned, all patients complain of weakness, tiredness, fatigue. Plus, all patients complain of anorexia. the majority of patients, over 90%, have gastrointestinal symptoms in the form of nausea, vomiting. Some of them have constipation, abdominal pain, of course, and some have diarrhea. Salt craving, يعني salt craving يعني ملهوف على الملح, occurs in 16% of patients. Postural dizziness occurs in 12% of patients. خلي بالنا, the patient may not complain of postural hypotension, but you as a physician, when you examine the patient, you will definitely find, you see, hypotension, particularly on assuming the upright position, in 88 to 94%, while symptom-wise, only 12% complain of postural dizziness. This is very important. يعني معناها, if the symptoms are not there, this doesn't mean that you shouldn't look for the sign. Is it clear? So again, the signs, all patients have weight loss. Over 90%, 94% have hyperpigmentation. Why do they have hyperpigmentation? Who can tell me?
عشان ال high ACTH برضه.
Exactly. Due to the high ACTH. Very good. Hypotension with a systolic less than 110 millimeters mercury, with further drop on assuming the upright posture. Here you have to wait for 2 minutes. Yani first you measure the blood pressure with the patient supine or sitting, and then you ask the patient to stand without any support. For 2 minutes. Why you have to wait for 2 minutes? In order for the sympathetic reflexes of the lower limbs to act. You give them time to act. And then you measure the blood pressure again with the patient standing. If you find a drop of more than 30 by 15, this is significant postural hypotension. As I mentioned, it's seen in 88 to 94% of cases. With the autoimmune causes of primary adrenal insufficiency, you may find vitiligo, like the one I showed you before with the autoimmune hypothyroidism. This is found in 10 to 20% of cases, and only 5% of cases may show auricular calcification. This is very rare. خلاص? Now let me show you the signs. So if you look at your palms, look at your palm creases. Are they the same color like these? Or are they different? Look at your, can you see my palm? Look at your own palms. What color are your palm creases? What color are your palm creases يا دكاترة?
Like the color of the rest of the palm.
طيب, أو a little bit darker, but not very dark like here, you see? These are the hands of a patient with primary adrenal insufficiency with dark palm creases. Not only that, but look at your fingers, the fingernails, the nails. Your nails are pink in color, right? No, here there is hyperpigmentation of the nails, particularly here. It's very obvious, you see? So hyperpigmented palm creases and hyperpigmented nail beds. Okay, type. And this is a lady, a female patient with primary adrenal insufficiency. She is of the Caucasian race, يعني من الجنس الأبيض. Look at the knuckles. You see, compare your knuckles to her knuckles. Her knuckles appear darker in color, right? This is another part of the body where to search for hyperpigmentation, يعني hyperpigmented knuckles of the fingers. Okay, type. Here is another patient with dark hyperpigmented palm creases and hyperpigmented knuckles, very obvious. Another patient with hyperpigmented knuckles. Okay, is it clear? Type. Not only that, but also on the olecranon process. Why? Because يعني hyperpigmentation is يعني seen on pressure sites. So you see, فلو احنا بنسند كده, you can compress the olecranon processes. This is why they become hyperpigmented as well. Okay? Type. What else? Hyperpigmentation over the inner aspect of the lip, where the upper incisors compress. Can you see my picture? You see? When you do this, the inner part of the lower lip becomes hyperpigmented. All right? This is apparent here. Is it clear?
Yes.
The dark line type. Not only that, but also you will find buccal pigmentations. You see here, maybe here it's more obvious. You see, hyperpigmented buccal mucosa. Why? Because it's caused by pressure of the teeth against the buccal mucosa. This means that if you have an edentulous patient, patient ما عندوش سنان, and he doesn't wear a prosthesis, you will not find the hyperpigmented buccal mucosa. Okay? Is it clear? Again, here to show you the area where the upper incisors touch the inner aspect of the lower lip. You see, it's very obvious, hyperpigmented. Hyperpigmentation of the inner aspect of the lower lip. Okay, and this is vitiligo. This is the normal skin color. Okay, but the milky white patch here is the vitiligo. Associated with autoimmune causes of primary adrenal insufficiency. Okay. And this is the hyperpigmented scar. You see, this is most probably a scar of appendectomy or something. But you notice the scar appears relatively old, right? With some keloid formation. But again, female patients come running. If this patient was a female patient, she will immediately notice the scar becoming hyperpigmented, and she's going to come running to see her doctor. Hyperpigmented surgical scars. Not only that, but also hyperpigmented nipples in males and females. Okay. Now, this is a very interesting picture. Of course, I've got it from the internet, Yani. These are two twin sisters. All right. Who can tell me who is the one who has Addison's disease? This one or this one? Who can tell me?
The one on the left.
This one?
لا, the other one.
This one. يبقى دي right, يعني مش دي right? The one on the right side. Exactly. How do I know? Because you see, this one is smiling. She looks very healthy. She has يعني rosy cheeks. The face is full, right? But this one appears depressed. She's very miserable, and she's dark in complexion. And she has dark lips, and she has loss of weight. You see? Very obvious. Very obvious. I like this picture very much because it shows you the difference between a healthy individual, this one, and a patient with primary adrenal insufficiency or Addison's disease. Okay, now imaging in Addison's disease. So far, any problems? Was I too fast? Very simple.
No,
Addison is very simple. Now coming to imaging. This is a plain X-ray of the abdomen. Okay? AP view. These are the vertebrae. This is the last rib. Okay. Here is the renal angle type. What is this? This is the renal shadow, by the way. This is something calcified on top of the kidney. Here's more obvious. This is the other kidney, and this is a calcified structure on top of this kidney. So what could this be? This is what? This is adrenal TB, and in adrenal TB, fibrosis of the adrenal glands occurs, and in 50% of cases, calcifications occur on top of these of this fibrosis, and it shows on plain X-ray like here. All right, very interesting. And this is a CT. Oh, you know the anatomy by now. This is a CT abdomen, CT abdomen at the level of the adrenal glands, axial cut with IV contrast. The aorta appears brighter than usual. Okay, let me revise the anatomy again. Posterior, anterior, right, left, the lumbar vertebra, the ribs on the right, the ribs on the left, the white structures. This is the spleen on the left side. This is the pancreas. This is the liver on the right side. And this is the abdominal aorta, as I mentioned. This is the right cross of the diaphragm. This is the left cross of the diaphragm. Now, we have two white arrows. What are they pointing at? This structure and this structure. What is this? What are these structures?
The adrenals.
طيب, why are they enlarged? طبعا يعني if you look at this CT, without having history, you may confound it with the previous CTs we have seen in Cushing syndrome, right? With the different causes, exactly similar. But clinically, the patient came presenting with Addison's disease or primary adrenal insufficiency. So what could be the cause?
Bilateral adrenal hemorrhage.
طب ما احنا قلنا hemorrhage would appear ايه بقى bright. Hemorrhage is مش كده هيبقى this color. بس are they this color? No. But what are these? Bilateral adrenal tuberculomas. Very rare condition. But you have to suspect. I will show you how an adrenal hemorrhage looks like. This is another CT abdomen. يلا. Who would like to comment? Who would like to comment? Come on.
CT abdomen.
Yes.
Axial cut.
Yes. At the level of which CT abdomen? At the level of what?
At the level of adrenals.
Yes, at the level of the adrenal glands, axial cut, with or without contrast?
Without contrast.
Sorry, without IV contrast, but with oral contrast. Yes. Showing what?
برضو bilateral adrenal enlargement.
This is the left adrenal اهي ودي left kidney ماشي وده السبلين اهو. This is the right adrenal ماشي. طيب ايه بقى؟ طب look at احنا قلنا without IV contrast صح؟ طب ايه رأيك؟ Do they appear bright in color?
Yes, bright.
Why are they bright? Why? فيهم hemorrhage. Bilateral adrenal hemorrhage. It turns out this is a patient with bilateral adrenal hemorrhage from anticoagulant therapy for pulmonary embolism. واضح ان ما كانوش بيعملوا له proper monitoring of the INR لو كان بياخد يعني warfarin. فحصل له يعني very unlucky to have suffered from bilateral adrenal hemorrhage. And the patient presented with primary adrenal insufficiency. You see? Very rare condition طبعا. But you have to suspect, otherwise you will lose your patient. لأن العيانين دول ممكن يدخل في adrenal crisis, and adrenal crisis is, as you all know, is one of the very dangerous endocrine emergencies that can be fatal. يعني. Okay. طب now look at this very interesting. طبعا I have never seen it. This is from the internet. But you have to suspect برضه. What is this? طبعا in those pictures it is very easy because you have arrows pointing at the pathology, but in real life لا, you have a CT, you have to look at it on your own and detect where the abnormality is. Okay, so who would like to comment on this CT? يلا.
برضو CT abdomen. Axial cut at the level of adrenals without contrast.
Yes.
Showing bilateral adrenal enlargement with peripheral calcification, I think.
Exactly, very good. This is a rim of calcification, and this is another rim of calcification. This is the right adrenal, this is the right kidney, this is the abdominal aorta, the right crus of the diaphragm, the left crus of the diaphragm, this is the left adrenal, and this is the liver. These are loops of intestine filled with oral contrast. This is the spleen. Very good. So this is what? This is histoplasmosis with bilateral subcapsular calcification of the adrenal gland. طبعا حاجة something that is very rare, but you have to suspect. يعني whenever you have a patient with primary adrenal insufficiency and you do a CT scan for his adrenals and you find a picture like that, you have to put the differential diagnosis in your brain in order to be able to diagnose properly. Okay, is it clear? طبعا it's very rare. You're never going to see it. Yeah, I never saw such a case. But just for brainstorming. Yeah. Any problems so far?
لا تمام.
Okay. طيب, this is a very interesting case برضه. يعني I like all the cases. Who would like to comment? حد تاني بقى غير الدكتورة مريم. مش الدكتورة مريم اللي كانت بتكومنت؟
أيوة.
طيب, somebody else بقى. يلا. دكتورة مها بشرى, I didn't hear your voice today. دكتورة ماجي, دكتورة آلاء حامد, I didn't hear your voice today. دكتورة Yasmin is waiting for me to admit her. Who would like to comment? يلا دكتورة ماجي would you like to comment؟ طب يلا.
CT
Yes.
CT axial view, adrenal view without contrast.
Yes.
with contrast بس في oral contrast.
Yes.
وفي الهايبربليز enlargement ومين دي جواها hemorrhage لأن هي hypoechoic.
طيب يعني في أو إيه؟ الصوت بيقطع. هي bilateral يعني في adrenal masses on both sides ولا on only one side؟
bilateral.
طيب this is the right أهي very large. This is the right crust, you see it's almost 10 times as thick and this is the left side. مش كده؟ شايفة كل دي وده left crust أهو يعني almost 15 times as thick. طيب أدي الabdominal aorta. طب what about the liver? Does it appear normal? What do you think? What is this? يعني what could the cause be of such adrenal enlargement? Bilateral. وpatient خلي بالك برضه presenting with primary adrenal insufficiency. ايه رأيك؟
دكتور هو الليفر كده مش نورمال صح؟
مش نورمال اللي هو ايه؟
الليفر مش نورمال.
لا مش نورمال برضه. ايه اللي فيه ده؟ شايفة في حاجات كده جوه؟ ايه بقى ده؟
وممكن الليمفوما ساعات بتعمل.
طيب يبقى this is malignant melanoma metastasizing to both adrenal glands. Always remember, if you have a patient with primary adrenal insufficiency and you find the patient very cachectic يعني you have to look for any possible tumor in the body يعني including مثلا breast carcinoma can metastasize to the adrenals. Very common. Very common. And the patient presents برضه with Addison's disease or primary adrenal insufficiency. هنا بقى malignant melanoma was metastasizing to the liver and to both adrenal glands. واخدين بالكم ازاي؟ You see? Very برضه very rare يعني very rare condition but you have to put in mind because if you don't suspect you will never be able to diagnose. فاهمين؟ يعني I'm bringing these challenging cases for you to يعني to work your brain. ماشي؟ Shall I continue?
Yeah.
Okay. Now coming to pheochromocytoma. تعبتوا ولا نكمل؟
لا نكمل يا دكتور.
مين اللي بيقول؟ دكتورة مريم شكرا صح؟ دكتورة مريم؟
أيوة يا دكتور أيوة.
دكتورة ماجي كمان طيب ماشي حاضر. طيب pheochromocytoma a clinical presentation is very interesting. There is a rule of 10, the famous rule of 10. بيقولوا ايه؟ Characteristics of catecholamine secreting tumors. على فكرة catecholamine secreting tumors are not only located in the adrenal glands. لا. They may be also located in the area of the stellate ganglion in the neck or in the pelvis في الحتة بتاعت the area of the organ of Zuckerkandel. خلاص يعني في extra adrenal يعني عشان كده بيقولوا 10% are extra adrenal. If you don't find the lesion in the adrenal, look elsewhere. Extra adrenal. 10% occur in children. The youngest patient with pheochromocytoma I have seen was a 10-year-old child. خلاص 10% are bilateral or multiple. Okay? I have seen برضو another patient who presented with pheochromocytoma on one side, which was surgically removed, and after some time, she came with another lesion on the other side. Okay, 10% recur after surgical removal. I have seen برضو, she was a nurse actually, who had her pheochromocytoma removed at Mansoura Faculty of Medicine. And then several years later, it recurred. Okay, 10% recur after surgical removal. 10% are malignant. Right. 10% are familial. This is why you have to look for it. You have to ask for the family history. Very important. Huh? Abroad, they screen family members of patients with pheochromocytoma for some genes that may predispose them to develop pheochromocytoma later on. And 10% of benign sporadic adrenal pheochromocytomas are found as adrenal incidentalomas. What is this? What is this incidentaloma? Who can tell me? What is an incidentaloma?
It's an accidental discovery of a tumor.
Very good. Very good. Very good. يعني the patient doesn't have particular reasons to do مثلا an abdominal CT or a CT on the area of the adrenals, but for one reason or another, he or she, they did it, and an adrenal incidental finding was seen or was discovered. So 10% of benign sporadic adrenal pheochromocytomas present as adrenal incidentalomas. This means that if you find an adrenal mass on CT, you have to check whether there is excess cortisol secretion, excess catecholamine secretion, or excess mineralocorticoid secretion. You have to exclude any of these, okay? To check whether it is functioning يعني or not, okay? طيب, what about the clinical presentation of pheochromocytoma? It is spell related. يعني spell, it comes in attacks. يعني the patient is not sick all the time. لا. In between attacks, he or she, they are completely normal. But during the attack, they complain of, they feel anxious, and they have this fear of impending death. يقول لك كأن روحي هتطلع. Diaphoresis, excessive sweating, dyspnea, difficulty of breathing, epigastric and chest pain, headache, hypertension. The blood pressure may shoot to very high numbers, nausea and vomiting. Pallor. Why does pallor occur? I insist pallor, not flushing. Pallor, because there is vasoconstriction. Okay? Pallor. Palpitations due to the forceful heartbeat, and of course due to the tachycardia as well. Tremors, fine tremors. Okay? What about the chronic presentation? يعني some patients with pheochromocytoma, they still complain in between the spells. What will they complain of? Again, anxiety and fear of impending death. They have cold hands and feet due to the peripheral vasoconstriction. They may show congestive heart failure. It may be either dilated or due to a dilated or hypertrophic cardiomyopathy. They have constipation. They have, again, diaphoresis, excessive sweating, dyspnea. And there may be symptoms dependent on ectopic hormone secretion, like, for instance, CRH or ACTH. CRH is chronic corticotrophin releasing hormone. ACTH, يعني ectopic ACTH secretion, or growth hormone releasing hormone, PTH related peptide, or VIP. But they are relatively rare. Epigastric and chest pain, again, fatigue and fever. Okay? General increase in sweating. Grade 2 to 4 retinopathy. I'm going to show you a picture of it in a minute. Headache, again, hyperglycemia. Yani they can develop secondary diabetes. Remember that. Hypertension, again. Nausea, vomiting. Orthostatic hypotension due to the diminished plasma volume. Painless hematuria, especially if it is due to a urinary bladder paraganglioma. It is a neuroendocrine tumor found inside the urinary bladder. In that case, it may present with painless hematuria. Again, pallor, never flushing, pallor. Palpitations, due to the forceful heartbeat and the tachycardia, tremors, and weight loss. Okay, so this is the fundus picture of a patient with pheochromocytoma having grade 4 retinopathy. What does it show? It shows the papilledema. Here, if you look at the normal fundus, you will be able to see here at the center of the picture the optic disc. But where is it here? It's not visible. Why? Because it is swollen, papilledema. The cotton wool spots, the white patches, hard exudates, the yellow patches, the flame-shaped hemorrhages. Okay, this is typical of grade 4 hypertensive retinopathy. The 10-year-old child that I told you about earlier had a fundus picture exactly like this. Imagine a child 10 years old. طيب, what about the typical spells or paroxysms? The episodic symptoms usually occur in spells or paroxysms. They can be extremely variable at presentation, but all of them, they include forceful heartbeat, pallor, again, pallor, not flushing, tremor, headache, and diaphoresis. The typical spell may start with a sensation of rush in the chest. يقول لك حاجة كده هب وطالع على صدري, and a sensation of shortness of breath, followed by pounding heartbeat. Tick, 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 tick. Okay? That typically progress to a throbbing headache. دماغه عمالة دق في دماغه. ها؟ طيب. Peripheral vasoconstriction with a spell results in cool or cold hands and feet and facial pallor. Again, pallor مش flushing. It's a common misconcept that the students say a pheochromocytoma spell is associated with flushing. This is wrong. Okay, remember, but pallor due to vasoconstriction. Increased sense of body heat and sweating are common symptoms that occur towards the end of the spell. Okay, وضحت? Is it clear?
Yes, doctor.
Great. Now, spells may be either spontaneous, لوحدها, or they can be precipitated by any of the following. Postural change, يغير, كان قاعد وقف, كان واقف قاعد. Anxiety, some medications, particularly metoclopramide أو metastatic anesthetic agents. عشان كده في السيرجري طبعا محتاجين proper preoperative preparation, يعني exercise, maneuvers that increase intra-abdominal pressure like change in position, lifting أو defecation, يعني straining, exercise, colonoscopy, pregnancy أو trauma. This nurse I told you about who had a recurrent pheochromocytoma, when we wanted to show the typical spell to our students and house officers and residents, we used to palpate her abdomen. Just by palpating her abdomen, the spell was precipitated. يعني حاجة عجيبة جدا. طيب, spells may occur multiple times daily or as infrequently as once per month. And the typical duration of a pheochromocytoma spell is around 15 to 20 minutes, but it may be much shorter or it may last several hours. Okay, however, you must realize that most patients with spells do not have pheochromocytoma. فدي حاجة مهمة جدا جدا جدا, تحتها مليون خط. Okay, now coming to imaging in pheochromocytoma. Imaging. This is a CT abdomen at the level of the adrenal glands. نفس اللي شفناه قبل كده. Posterior, anterior, right, left, vertebra, abdominal aorta, the ribs on the right, the ribs on the left, the liver on the right, the spleen on the left. This is the abdominal aorta, the right crus of the diaphragm, the left crus of the diaphragm, and the white arrow is pointing at this lesion. You see, this is a huge, a very large left adrenal mass. طبعا, if you just by looking at the CT, you cannot say whether it is an adrenal carcinoma causing Cushing syndrome or a pheochromocytoma causing the spells. Okay, you cannot. So this is why you need to do first the hormonal assay and then do the imaging. So this is a very large, partially vascular. You see, because here it took up the contrast, the intravenous contrast, and partially necrotic, the relatively dark areas, left adrenal tumor. Of course, since the size is larger than 5 centimeters, it is most probably a malignant pheochromocytoma. Is it clear? Anything that is difficult? All right. Type. Now, this is an MRI of the adrenal gland. How do I know it is an MRI and it is a T1 weighted image? Because here the CSF is black. Okay, this is the vertebra. This is again posterior, anterior, right, left. This is the vertebral body. This is the spine. The spinal cord surrounded by black CSF. So this is T1 weighted. This is the right crus of the diaphragm. This is the left crus of the diaphragm, the left kidney, the spleen, and the liver. This is the area of the gallbladder here. And this is a right heterogeneous, you see, pheochromocytoma. Okay? Right adrenal mass. It's rather large, 3 by 3, 3.3 by 3.5 by 4.5, heterogeneous. Okay? And this is the T2 weighted image. You see the CSF turned white. That's my cursor. The CSF turned white, you see? This is posterior, anterior, right, left, the liver, the spleen, the gallbladder, and this is the aorta, the right crus of the diaphragm, the left crus of the diaphragm, and here is the left kidney, and here is the right adrenal pheochromocytoma. Okay? It showed an increased signal intensity. You will tell me, Tom, how do I distinguish an MRI of the adrenal from a CT? You see, the CT appears very clear, while an MRI appears relatively blurred. Is it clear? And
Yes.
of course, you have a T1 weighted image. Don't confuse the CT with the MRI, Dr. Maggie, and a T2 weighted image. Tom, you will tell me what is the importance of doing an MRI? In other words, which is more sensitive for detecting an adrenal tumor? Of course, the CT. But our colleagues at the urology department, if they suspect a malignant adrenal mass, they prefer doing, in addition to a CT abdomen, also an MRI. Why? Because there is a certain technique called wash-in, wash-out phase, through which you can pre-operatively determine whether this lesion is benign or malignant, because of course the approach will differ. If it is a benign lesion, he can do the removal through the laparoscope, but if it is a benign, a malignant lesion, they will have to do most probably open adrenalectomy in order to dissect any lymph nodes that are present. Is it clear?
دكتور معلش
Yes.
هو اللفت ادرينال هنا باينه
اللفت في انه في ايه؟
هنا في الام
اهي شايفاه؟ اهي
تمام
فوق، يعني كأنها زي طربوش كده واقفة على يعني على posteromedial aspect of the left kidney. شايفاه؟ زي inverted Y.
تمام.
Okay, very good. طيب okay. طيب now coming to scintigraphy again. scintigraphy فاكرين لما في الثايرويد قلنا بنعمل radioactive iodine or technetium 99. اوكي في الباراثايرويد بنعمل ايه؟ technetium 99 sestamibi scan. اوكي في الectopic ACTH secreting tumors بنعمل octreotide scan. ده indium label مش مهم يعني التريسر. في الفيوكروموسايتوما you do an MIBG whole body scan. طيب it's not done routinely الحقيقة لأن it's very expensive and it's not readily available. الناس بيروحوا كايرو عشان يعملوه يعني. طيب here it is very obvious. يعني this is the anterior view. خلاص يعني مصورين patient from the front view and from the back. طيب let me show you. برضو it is taken up by شايفين هنا the parotid gland and the submandibular salivary gland. هنا برضو part by the liver. بس هي متركز فين؟ في الليفت adrenal. شايفين؟ left adrenal. وبرضو في شوية في اليورينري bladder لأن هي excreted. طيب شايفين هنا؟ دوت من ظهره بقى. This is from the back view. It is concentrated in the left adrenal gland. This is easy. This is easy. I mean, this is an easy case. It is usually resorted to locate يعني suspected pheochromocytomas that are extra adrenal. Yeah, it is exclusively done, better يعني exclusively done in cases where you suspect there is مثلا something in the stellate ganglion here or in the organ of Zuckerkandel here. Okay, or a urinary bladder paraganglioma, as I mentioned earlier. But this is very obvious. يعني هنا دي كانت هتبان في السي تي أو في الام ار اي. فno need to do an MIBG scan. Okay? Is it clear? But just to show you, how it looks like. خلاص؟ طيب برضه بقى the most يعني the best way to locate a difficult pheochromocytoma is by combining an MIBG SPECT يعني technique with CT images, because you see the CT shows you the anatomy. This is the axial, this is the coronal view, and this is the sagittal view. Okay, and the physiology يعني the uptake يعني of the tracer can be seen by the MIBG SPECT. Okay, if you fuse both images together, put this on top of that, you have better diagnostic resolution here. But of course, this is an obvious lesion. Yeah, it would have برضو appeared on CT. I'm talking about localization of very small and lesions that are secreting catecholamines, but they are not localized by CT or MRI. Is it clear? Huh? Any problems?
لا تمام يا دكتور.
Okay. طيب تعبتوا ولا نكمل؟ آخر حاجة كونز بقى، كونز disease. طيب Conn's disease is it's يعني in the clinical picture. I have actually seen two patients, a male patient and a female patient. Both of them were in their 50s. Both of them were obese, بس مش مهم الobesity. المهم ان هما both of them had uncontrolled hypertension. The male patient was taking like 5 drugs in maximum doses, but he wasn't controlled. And the female patient presented with hypokalemia, severe hypokalemia. The serum potassium was 1.9. Okay? طيب يعني this shows you many patients are asymptomatic. They have no symptoms, but they may have features of sodium retention or potassium loss. خلاص? Sodium retention may cause edema. The female patient had ankle edema. Hypokalemia may causes muscle weakness, even paralysis, especially in the Chinese. And polyuria. Why? Due to renal tubular damage, which produces a nephrogenic form of diabetes insipidus. And occasionally tetany occurs. Why? Because of associated metabolic alkalosis, which leads to low ionized serum calcium level. Okay? Okay? طيب what about investigations? Biochemical investigations have to be done first. Of course, you need to do the plasma electrolytes to search for hypokalemia and elevated bicarbonate. Regarding the plasma sodium, usually it is towards the upper end of normal in primary mineralocorticoid excess, but it is characteristically low in secondary hyperaldosteronism. Why? Because low plasma volume stimulates ADH release, and high angiotensin 2 levels stimulate thirst. خلاص؟ فكأنه يعني ايه؟ كأنه في زي delusional كده يعني. ماشي؟ طيب. Now coming to plasma renin activity and aldosterone. If renin is low and aldosterone levels are high, then you can diagnose Conn's disease. Okay? And you can differentiate it from bilateral adrenal hyperplasia by doing tests of aldosterone response to angiotensin 2. But we don't have them actually يعني. We don't do them. I mean, we don't do them يعني. طب in Conn's adenoma بقى, aldosterone does not rise on standing or with furosemide administration. But this is برضو an important test يعني, diagnostic test. In the rare circumstance where renin and aldosterone are both low, then you need to do further measurements of urinary cortisol and its metabolites and 11-deoxycorticosterone. Okay? طيب المشكلة بقى إن before doing the investigations, usually the patient presents with hypertension. So he or she, they are taking many antihypertensive drugs. Almost all antihypertensive drugs interfere with these hormones. Beta blockers inhibit renin secretion while thiazide diuretic stimulated. So they should be stopped at least for 6 weeks, if possible. Yeah. If this is not possible, then you have to choose antihypertensives which have minimal effects on the renin-angiotensin system, like calcium antagonists and alpha blockers. Okay. يعني ما نديش بقى ARBs, angiotensin receptor blockers, ما نديش angiotensin converting enzyme inhibitors. الحاجات دي كلها they have an effect on the renin-angiotensin system. Okay, this is very important. After doing having done the biochemical diagnosis, you need to locate where it is. خلاص. The only cause of primary hyperaldosteronism which can be treated by surgery is Conn's adenoma. يعني an adrenal adenoma that looks exactly the same like the previous pictures I have shown you of the CT abdomen, but it is secreting excess aldosterone. خلاص? So abdominal CT is often the only test required to localize the tumor. خلاص? But it is important to recognize that non-functioning adrenal adenomas are present in about 20% of patients with essential hypertension. يعني لو جبنا 100 patients who have essential hypertension and you do a CT abdomen for them, you can find non-functioning adrenal adenomas, برضو incidentalomas يعني. خلاص? So adrenal CT should only be performed when the biochemistry supports the diagnosis of an adrenal tumor. This is very, very, very important. Okay يا جماعة؟ خلاص؟ طيب, if the adrenal CT scan is inconclusive بقى, يعني انت عندك high aldosterone بس مش لاقي فين طالع منين, هنعمل ايه ساعتها؟ Then you can do an adrenal vein catheterization, حاجة invasive بقى, with measurement of aldosterone and cortisol to confirm proper positioning of the catheters, or you can do something, a scintigraphy, using radioactive labeled iodonorcholesterol. I will show you how it looks like. Coming to the imaging of cons. Any problems so far? Am I going too fast? Huh?
لا تمام يا دكتور.
طيب اوكي. Imaging بقى. ادي سي تي تاني اهي. سي تي ابدومن. خلاص؟ مين يقول لي بقى؟ يلا. بقيتوا experts في السي تي. ها؟
CT abdomen.
Yes.
Axial cut.
Yes.
Without contrast at the level of adrenals.
لا خلي بالك بقى. خلي بالك. Without contrast. امال ايه الابيض اللي جوه الكيدنيز ده؟ ايه الابيض ده؟ هي الأورطة معاكي حق. The aorta appears يعني somewhat gray in color. Huh? Maybe the patient has renal stones because these are, you see, the same density as bone, right?
Yes.
Okay, طيب. What else? Showing. ايه بقى؟
هو أنا شايفة سهم مشاور على الليفت adrenal فمش واضح إن في يعني.
طب I will show you some structures. I will point at some structures and you tell me what they are. What is this structure?
Spleen.
طيب. What is this structure?
Liver.
Voice. What is this structure?
Right kidney.
Okay. What is this structure?
Left kidney.
طيب. What is this structure?
Abdominal aorta.
Okay. Here, mind you, the right cross and the left cross of the diaphragms, of the diaphragm are not visible. So we are at a lower cut, يعني, huh? Because here you can see the kidney, the right kidney is cut across, يعني, and you can see the cortex and the medulla, and you can see the renal stones inside. And here as well, you can see the left kidney, the renal cortex and the adrenal medulla. Both. فواضح ان هي we are at a lower level, huh? The crura of the diaphragm are not visible. But you know that this structure is related to the posteromedial aspect of the kidney, the left kidney. So it has to be a left adrenal mass. Okay?
Yeah.
This is a left adrenal mass. We cannot, just by looking at the CT, we cannot say whether it is secreting excess cortisol, excess catecholamines or excess aldosterone. This is why I'm stressing again. This is why you need to do the hormonal assay before asking for the imaging to localize. Okay?
دكتور معلش هي الرايت ادرينال هنا مش باينة.
ثواني بس. right adrenal لحظة واحدة. أيوة. the right adrenal لا. because why? You see هي أنهو level أعلى؟ أنهو which is higher, the right kidney or the left kidney?
لا الليفت كدني.
طيب يبقى هنا we are at a higher level. This is why here you can visualize the left adrenal and here you don't visualize it because already the right kidney is cut across. يعني انت هنا في نص the right kidney يمكن. فخلاص يعني the right adrenal كانت at higher cuts. You have to look at higher cuts of course, but it's not visible in this cut. Okay? Okay, is it clear? Type. Now coming to the scintigraphy. Scintigraphy of the adrenal. It's a different form of tracer, radioactive. Here they have used radioactive iodine labeled nor cholesterol. Why in particular cholesterol? Who can tell me? Why cholesterol?
عشان الفات بيروح الادرينال جلاند.
Here the adrenals are the adrenal gland. Here we are talking about adrenal cortex مش كده؟ adrenocortical يعني lesions. طب هي الادرينال cortex بتعمل ايه؟ الستيرويد هرمونز. steroid hormones have the building block of steroid hormones is what? Cholesterol. So if you want to visualize the adrenal cortex, you need to use a radio tracer labeling cholesterol in order to be taken up by the adrenals. Is it clear? So here you have, this is a clear case, a clear-cut case, because here you have nothing, but here you have tracer is concentrated in the left adrenal adenoma. It is said that the radio tracer is exclusively taken up by an adrenal adenoma, but not by the normal or the contralateral suppressed adrenal. Type. The importance of this is what? If you have bilateral pathology, but you cannot visualize it on CT adrenals, and you do this, and you're suspecting that there is a bilateral pathology. If you do a radioactive labeled iodo nor cholesterol scan and both adrenal glands are visualized, this means that you have bilateral pathology, like what occurs with primary pigmented nodular adrenal disease. Okay, but if it's like here, only visualizing one adrenal adenoma, then the other adrenal gland is suppressed because why? Whenever you have an adrenal adenoma, it is autonomously secreting. So the other adrenal gland will definitely be suppressed. This is why it doesn't take the radio tracer. Is it clear?
مش عارفة يا دكتور صراحة اتلخبطت شوية في الحتة الأخرانية دي يعني
من أول فين؟ من أول فين؟
الحتة اللي هو unilateral ولا bilateral؟
بصي دلوقتي احنا ممكن يكون عندنا bilateral pathology in both adrenal glands. خلاص؟ طيب بس لما تيجي تعملي CT only one side is visualized فهيتهيأ لك إن هي unilateral adrenal pathology while actually both adrenal glands are involved by this pathology. خلاص؟ طب if you suspect it بقى, how can you prove if it is only unilateral affection or bilateral affection? Simply by ordering this iodo nor cholesterol scan. Why? Because it is reported in the literature that this tracer is taken up exclusively by an adrenal adenoma, but not by the other suppressed adrenal. Whenever you have an autonomously secreting adrenal adenoma, بالضرورة the other adrenal becomes suppressed. Okay? So it's واضح?
فهمت.
Okay, fine. And this is how يعني this is the surgical specimen. They have removed the adrenal gland. Okay? And on cut section, it appears canary yellow in color because of the high intracellular lipid content. Is it clear? So a patient اللي أنا قلت لكم عليها كانت she was from Libya. She came presenting with headache due to uncontrolled hypertension, and she had weakness due to hypokalemia and bilateral ankle edema. And it turns out that her serum potassium was very low, 1.8, I think, or 1.9. And it turns out that she had a primary hyperaldosteronism due to a lesion on one side. And the urologist requested, in addition to the CT of the abdomen, he requested also the MRI technique I told you about, the whoosh in and the whoosh out phase, to determine whether it is a benign or a malignant lesion. And it turned out it was a benign lesion. And he did the adrenalectomy, and it looked exactly like this. Okay. After adrenalectomy, the nice thing is that the blood pressure of the patient became controlled very nicely, and she could actually stop the antihypertensive medication. So it's one curable form of hypertension, secondary hypertension, of course. But of course, it depends on the duration. If the patient had long-standing hypertension, and which caused already the remodeling, vascular remodeling, of course, it won't be reversible. So this patient was lucky enough to have been diagnosed very early in the course of her disease, and so that her hypertension could have been reversed, although she was in her 50s. Okay. This is it. We have revised almost all the endocrinology. So I hope, it was beneficial for you. And as usual, I'm putting for you the evaluation of today's revision session in the chat of Microsoft Teams. So please kindly fill it out. You are 6 students with me now, so I expect to find 6 responses. Any questions so far? Any
Doctor,
problems?
I have a question in Cushing syndrome.
Yes, tell me.
I have read in some textbook in Cushing syndrome there is virilization in female but a secondary hypogonadism in male. فيعني ده يعتبر مش قادرة أفهم ليه هنا مثلا virilization وهنا hypogonadism.
Very good question. Virilization actually مش virilization بقى هنا hirsutism. What is the difference between virilization and hirsutism يا دكتورة أمنية? Is there a difference or are both the same?
الفيراليزيشن هيبقى فيه affection بقى للفويس والبادي muscle distribution في البادي.
ايوه، وفي كليتوروميجالي كمان، في كليتوروميجالي يعني معناها ان هي بقت كانها بقت زي الراجل ها. طيب انما hirsutism only presence of terminal hair in androgen dependent areas in a female. خلاص. طب ليه بقى بيحصل في الرجاله بقى الهايبوجوناديزم بقى؟ ايه رايك؟
اللي انا في قعدت ادور لقيت مثلا ان الكورتيكويدز مثلا ليها inhibitory effect على الجونادوتروبينز، بس ايه الميكانيزم؟ هل هو ده الميكانيزم؟
هو بصي خلي بالك excess cortisol. if you look back to your physiology, if you revise your physiology, we'll find that glucocorticoids in excess, they can affect all systems of the body, including the endocrine system. خلي بالك. On the endocrine system, what are the effects of excess cortisol? Number 1, they decrease TSH secretion from the pituitary. Number 2, they can decrease secretion of gonadotrophins from the pituitary body. واخده بالك ازاي؟ They can decrease linear growth in children زي ما قلنا through the effect on IGF-1. Okay? لأن growth hormone acts through IGF-1. Okay? كمان they can decrease the conversion of T4 into T3. You know that the normal thyroid secretes 80% T4, but the metabolically active hormone is T3. So it has to be converted in peripheral tissues through 5-deiodinase enzyme into T3. Corticosteroids inhibit this enzyme. Okay? So it has a multitude of effects on the endocrine system. بدليل in ladies, not only hirsutism occurs, but also they have amenorrhea, right? ما هي amenorrhea دي برضه من الهايبوجوناديزم. Okay? Can you hear me, دكتورة أمنية?
Yes, doctor, yes.
Okay? طيب.
Okay.
Very good. Any other questions? Can you see the responses? I have 4 responses till now. 4 responses. The 2 remaining students, would you please be kind enough to hurry up and answer so that I can read out the responses to you? Huh? Because all of us are very tired, particularly me, Yani. I had a very long day today. And I'm much older than you are. Yani, my tolerance to fatigue is much less than yours. Huh? Would you be kind enough to answer the remaining students? Huh? Very bad attitude, Yani. I asked you to kindly, only one thing I asked you to do. Please answer the survey, and you're refusing to do so. Very bad attitude, actually. Very bad. Right. Anyway. The second revision session, this is not the second, this is the third. The third revision session added much to my knowledge and clinical skills. 100% strongly agree. This is very nice. The timing of the session was appropriate. 80% strongly agree, 20% agree. The discussion added much to my knowledge and clinical skills. All of you, 100% strongly agree. This is very nice. Microsoft Teams is easy to use. 60% strongly agree, 20% agree, and 20% disagree. I wonder why. The sound quality was good. 80% strongly agree, 20% agree. Overall, how satisfied are you with the webinar? 100% are very satisfied. This is very nice. What did you like most about the webinar? Thank you so much for your efforts. The revision was very helpful. You're most welcome. The session is very good. Smiley face. All conclusive, thanks. Okay. The radiology images and the overall revision. Nice. The overall revision is very beneficial. Thank you. Variety of cases. Very nice. What would you like to suggest to what would you suggest to improve the webinar? Nothing. No, it is perfect. Nothing to be added. Thank you very much for your patience and for bearing with me. I know it was very long and very tiring, and you have exams coming up. So I just hope it was beneficial. And as always, you can access the video recording through the chat after we finish the session. You can access it again through the link that Dr. Ahmed Ale has sent you. Look in the chat. There are 3 dots beside the video recording, and then you can click on them, open in streaming. Another window will open. You have to log in through your official email at alexmed.edu.eg, and you can view the video. Okay, any questions before we leave? Any comments?
شكرا يا دكتور جدا.
أهلا وسهلا. أهلا وسهلا. نورتوني وشرفتوني. I wish you the best of luck inshallah on your upcoming exam. السلام عليكم ورحمة الله وبركاته. Good luck.
شكرا دكتور.
Thank you.